Test 1 1. Test 1 1. Oh, here we go. Here we go. Test 1 1. Test 1 1. Now it's a little hot. Test 1 2. Test 1 2. Test 1 3. Test 1 3. Test 1 4. Test 1 4.
Hearing none, I would take a motion to move. So we have a move to approval. Do we have a second?
Second.
Second. All in favor, signify by aye. Aye. Any opposed? All right, approval passes. Next item, quality reports and updates not requiring committee actions. So we have the Dr. Charles E. Weber Jr. Golden Mitt Award presentation. Dr. Stevenson, welcome.
Thank you. Okay. So we have 4 golden bits to present to you that have been awarded since the last time we talked about these. We're going to start with the emergency department. Can we go forward in the slide deck, please? Oh, it's over here. I'm sorry. I went to the wrong mic. There we go. So this is our April award winner, the ED. It is with great pleasure that we announce the April 2022 Dr. Charles E. Weber Jr. Golden Mitt Award winner is the emergency department. This team was nominated by the Department of Clinical Risk and Accreditation, and here are just some of the reasons this group of amazing professionals were nominated. In the last 12 months, over 118,000 patients were served. It's an average of 9,847 per month. The volume alone is staggering. The ED has been faced with major staffing challenges, leadership changes, changes in major processes, and more. They've consistently maintained their commitment to patient care through core measure committees and shared government's involvement. They stepped up with support and engagement for every RCA and ACA. They've initiated programs geared toward growing their culture of safety and evidence-based practice, while creating a workplace in which staff not only want to come to work, but they encourage their friends to come and work as well. During all of this, they've continued to report their safety concerns and process improvement ideas every single day. The emergency department's answer to every gauntlet thrown has been to own it and step up. We recognize your hard work, your dedication, and are so proud to support you in these efforts. Congratulations to our JPS Emergency Services team. Very good. Great.
Where are they? Which
Do we
ones
have
are they?
any representatives? There we go. Can you step forward and be recognized, please? Sure. Thank you.
All right.
Next, we have another group of MVPs around the health network, and that is, go forward, there we go, here's our emergency department team. The next is our MET team, Medical Emergency Response Team. It is with great pleasure that we announce the recipient of the May 2022 Dr. Charles E. Weber Jr. Golden Mitt Award is our MET team. They were nominated by the Med-Surg and Critical Care consultants from the Clinical Risk and Accreditation team. Here are just some of the reasons this group of amazing professionals were nominated. This team of nurses are an invaluable resource and have a great impact on nursing and patient care throughout the hospital, which reduces length of stay and mortality. The team conducts house-wide mock code blues on a regular basis to increase our patients' chances of surviving an arrest. They respond to all codes and own the situation. They bring a sense of calmness to our staff during and after stressful events. The team is always willing to take a phone call, answer questions, spot check a patient, help with a hard IV stick, and assist with any patient needs. They are responsive to staff concerns, and they take time to educate staff and patients. It is through these efforts that the MET team was nominated. Congratulations to all. And with the MET team, representatives step forward, please. And here's our MET team. So we have a somewhat of a joint winner for June, our probes committee and the Department of Radiology. It is with great pleasure that we announce the recipients of the June 2022 Dr. Charles E. Weber Jr. Golden Mitt Award is our probes committee and the Department of Radiology. They have been nominated by the Infection Prevention Department. Here are just some of the reasons this group of amazing professionals were nominated. They supported and assisted with established standardized high-level disinfection processes within a multidisciplinary interdepartmental group of subject matter experts, otherwise known as the Probes Committee. Such processes were highlighted by the Joint Commission during our survey as noted best practices. They supported and assisted in establishing best practices for providing high-quality, safe ultrasound use throughout the network. Such best practices have been since requested by Vizient after we had no findings during our Joint Commission survey. They further developed and assisted in establishing robust standardized education, training, and competency required upon hire annually and as needed. Nanosonics praised us for being the only health system other than MD Anderson in the region with such standardized and streamlined best practice expectations for quality care as well as patient safety with ultrasound probe processes and reprocessing. General Ultrasound is always ready, willing, and flexible in leading the charge with any voted best practice change through committee and quickly establish them as routine practice. It is through these efforts that the Radiology Probes Committee Department was nominated. Congratulations to all. And I just want to say, as an editorial, if we go back to when we had a mock survey done back in 2020, these areas of reprocessing of probes, surface probes and other probes was cited as a significant weakness for us. And this probes committee came together actually under the leadership of Dr. Saltarelli from the emergency department, who really major impact, phenomenal leadership. I think we should expect to see lots more from Dr. Saltarelli in the future around this organization. He's pretty impressive younger physician, but really provided tremendous leadership. And then the radiology department, particularly the ultrasound team, the quality team over there and stuff, really helped drive this across the network, so with the help of infection prevention. So really a phenomenal team effort, and we went all the way from an area of real weakness to now we are the leader in the country in this, and that group really did this. And so like everybody's now asking us for, how are you doing this? How are you doing this? How are you doing this? And that's where we've come to. So really a phenomenal accomplishment. So I really want to recognize that group. So the Radiology and Probes Committee, please come forward. All right, and here they are. Finally, for the month of July, P5, so Pavilion 5, it is with great pleasure that we announce the recipient of the July 2022 Charles E. Weber Jr. Golden Mid Award is our Pavilion 5th floor department. They were nominated by the Clinical Risk and Accreditation Department. Here are just some of the reasons this group of amazing professionals were nominated. They decreased heparin drip errors by nearly 100% in a short time span. They increased blood transfusion documentation from 75% compliance to 92% compliance. They increased critical drip vital sign compliance monitoring and documentation from the low 70s to 97%. They increased staff huddle attendance consistently over the past year. They started the Wedge This Way program in May 2021 to prevent wounds through turn compliance and offloading heals, also aiding in the early identification and treatment of wounds. They had no CAUTIs or CLABSIs as a big, busy unit, mostly doubled for all of 2021. Wow. That's amazing. Wow. P5 was also recently recognized by the geriatric program manager for the care they delivered to an 82-year-old patient with dementia. It is through these efforts that the P5 team was nominated. Congratulations to all, and if the P5 people would step forward, please. And there are some of them right there. All right. I'm going to turn it over now to Dr. Gandhi and Cassie to talk about our recent level 1 verification survey.
Thank you, Dr. Stevenson. Congratulations to all of our winners. Job well done. Hello, sir.
Hello. Thank you very much. My dyad partner could not be here. She needed to take care of her family, so and I fully support her endeavor there. First slide, please.
You have
You have the clicker.
I have it. Awesome.
You have the power.
So, level 1 trauma re-verification survey. So we've had 5 level 1 re-verifications with no criteria deficiencies. This is being our 5th. As far as I know, we are the only level 1 center in the Metroplex that has had that distinction. Our strategic alignment is to our culture of excellence. We've been continuously verified, which means the American College of Surgeons comes and evaluates us with over 300 criteria to make sure that we are able to meet those criteria. And once we have been verified, the state then designates us as a level 1 trauma center. The enhancement to community service and access to our specialized care, which is trauma care for all of our community, we've done continuously since 2009 as level 1. When we had our verification, our official letter came January of 2010. The trauma center improves care for the injured patient by setting standards that define the structure and processes of care. So what are those processes? One of those is one that we practiced quite a bit over this weekend, and I think we're now professionals about it, which is going from the emergency department to the operating room within minutes. So if in my trauma tour, we actually take that walk, and you can see how little time there is between the trauma bay and the actual operating room. And that's the only time that our operating room has to get anesthesia ready, the nurses ready, the techs ready, the equipment ready. It's really a very little amount of time. And then the other process is what happens if you have more than one trauma, which we did over the weekend, or what happens if there's a trauma in the ICU that needs to go back to the operating room. Well, you have to have processes to be able to get all of those patients in a timely fashion. And so we have all of that. We measure our patient outcomes through national risk-adjusted benchmarking, and that allows us to go through and say, okay, are we able to say we are a national outstanding center of excellence in trauma care? And we are. We promote best practices, evidence-based guidelines, and adhere to the performance improvement principles. We also implement injury prevention, outreach, research, and scholarship, and we had strengths, as you will see shortly, in all of those. So these were the strengths that have been identified, and I do surveys myself, and usually we give out maybe half of these. So I think we really do have an outstanding program, and it's not just me saying it because I'm the medical director, it's somebody else from the outside coming to tell us that. So the first strength, and a thank you, is administrative support. And that administrative support is our CEO and administration, as well as you all as the Board of Managers. We would not be where we are without you all and your strong support that we've received every single time we come here. Myself and my dyad partner, involvement in regional and national trauma systems, trauma performance improvement and patient safety program, and that's our program that we go through to make sure that we're able to take care of every single patient excellently every single time. Integration of EMS feedback into our performance improvement and patient safety program and plan, our trauma nurse clinician program in the emergency department, our trauma-related professional education programs. We have a program that was started by Cassie Lyle, that's the medical director on the administrative side, which is our trauma video debriefing program where we videotape our resuscitations and go over them to make sure that we're able to have good team play and make sure everything works as it's supposed to, so we get those patients efficiently out. Our ED ultrasound program, diagnostic radiology services, anesthesia and operating staffing models, blood transfusion protocols and processes, and you'll see that we've become a level 1 center of excellence in patient blood management, and Adrian will go over that shortly. Expanded services for minor burn patients, geriatric trauma services, so that's a service that we actually started way back in 2013 and have built that up to a model for the nation. community education, outreach, and injury prevention programs, research and scholarly activities, and our organ procurement rates. We did have some opportunity for improvements, and I'll go through the opportunities and then some of the things that we've already started doing to correct those opportunities. Our survey was April of this year, first week of April, and so we got our final verification report just last month. So we've been working since they left to make sure and take care of these opportunities as quickly as possible. One, expand trauma assessments for injured patients admitted to non-trauma service. So what that means is we have patients who are put on non-surgical services, and we want to make sure that if they have injuries, that we follow them through. Expand the quality review of our pre-hospital EMS care, and so we've already expanded that program in order to review every pre-hospital case. Incorporate ultrasound assessments into our performance improvement patient safety plan, and that is still a work in progress. Reduce ED and ICU nursing turnover. So at the last survey in 2018, that was actually a strength for us. And with Rona coming in, that has changed. So I'm sure that will go back to being a strength in the not too distant future. The reduced ED left without being seen rates is high. And so we have a large institutional program to work on that as well. Enhanced neurosurgical documentation. So we've already covered that and taken care of that with smart phrases for our neurosurgical colleagues. Lack of a specialized surgical trauma ICU, and that's something that we'll discuss on the next slide. Expand trauma-related education standards for our PACU nurses, and that we've already started implementing. So our next steps, again, areas of focus and action plans. Expanded quality review of our EMS care. We've already started. We're working on getting more, especially more direct communication with our EMS colleagues, the biggest one being MedStar. Quality review of our FAST, which stands for Focused Assessment of Sonography and Trauma Exam. So that's an ultrasound-based review, and so that we've had, and we're now making it more robust. And then nursing staff, the retention and recruitment, there's been a number of items being worked on by quite a few people. Trauma-related education in the PACU, as I said, we've already started. And then trauma specialization in the ICU. So we want to implement a program similar to the one that we've done in the emergency department with trauma nurse clinicians in the emergency department, to have trauma nurse clinicians in the ICU. We are not able to have a separate trauma ICU, and we all understand that. The American College of Surgeons understands, however, they feel like that would be the best way. And so what we're trying to do is have a virtual trauma ICU by having our trauma nurse clinicians in the ICU. Documentation, the neurosurgical decision-making documentation, we've fixed that with smart phrases. And then trauma assessments for all patients admitted to non-trauma services. We have a process where we have one of our advanced practice professionals go and see these patients on the other services and do tertiary exams. And then if there's an issue, then we are all notified about that and we make them part of our service. And finally, the process is to reduce our ED left without being seen rate. Our next verification, if anybody is interested in being there, is going to be in April 2025. So obviously we start planning well in advance, and we've already started planning for our survey in April 2025. Thank you so much for your attention. I'll be happy to take any questions. Go ahead.
Dr. Gundy, probably redundant comments, but the number 4 on opportunities identified, and then the number 2 on next step, basically, at our last board meeting, I mean, that's a problem hospital-wide, though.
Yes, sir. So left without being seen rate is...
No.
Talking about staff.
Oh, yes, yes. In the last survey, that turnover rate was about 8%. And so it's gone up quite a bit, as we know, for a number of reasons. We've had increased burnout, not just of nurses, but other staff. We've had staff that are, on the borderline of retirement, retiring early. And so there's been a number of factors that have pushed that. And there's many people that are working very, very hard, coming up with very innovative ideas to keep the nurses that we have, bring the nurses back. So I was in the ICU this last week, and I saw a lot of the nurses that had left coming back. And they come back because when they go to other places, they see that the grass really wasn't greener on the other side. And they come back. And so I believe that over the next year, we will see more and more.
Dorothy to come back.
Yes, and
Just an absolute number. Well, you had 8% before, now you have 20%, so that's bad, but.
yeah, no, that's a great question. So I do trauma surveys. So last year I did 12 surveys, about one a month at different institutions, usually level 2 and level 1 institutions. And there was only one center that had the retention that was close to ours. It was about 11% recycle rate, 11%. And so we asked them, how were they able to do that? Because that was the only center out of 12 that I verified or surveyed that had that. And their answer was that they just make it very easy for the nurses. And I said, what does that mean? And he said, well, think of something. And so I threw something out, and he said, so this is what we do for that. And so I thought that was fairly interesting. However, their locale, it was a California institution. I think it makes a difference. And then most of their people are within their local area. And they don't have very many other centers in that particular area except that one. So geography is huge. And I believe that was a bigger part of kind of their retention and not having to recruit and low turnover.
Any other questions?
Oh, yeah. No, we've been very good in terms of recruitment. We have a turnover in trauma as well, and our nurses get quite a bit of trauma training, and it's not just trauma training, but it's the one step over, which is the quality improvement, the patient safety aspect, the performance improvement, and those skills are hard to find. And so our trauma nurse clinicians are very much coveted by our local environment. And so we have had a few that have left, and after leaving, usually 3 to 5 years later, they've come back as well. So we feel like we do have a lot of training, and we do spend a lot of time, energy, and obviously financial resources to do that. And I think it's important for us. And some people would say, well, it's part of our responsibility to make sure that if we have these outstanding people, and that we share them with our colleagues around the Metroplex. And certainly that happens just by kind of the way history happens.
Rotating through the ICU?
Yes.
Okay.
So most of the things, when we talk to them after this, we ask them, so what would kind of help us to to be able to get to that point where it's not a deficiency. And so the first answer was, well, build a new ICU and have a trauma ICU separately. And I said, well, that's not going to happen even by the next survey. So what would be the next? And so we feel that that would be the way. And so they said, well, we'll probably still put that you need to have a separate ICU, but let's see what happens. So what they're looking for is, how does that change your patient care? And if they can't show that the patient care is different with our trauma nurse clinicians in the ICU that we have versus having a separate ICU, then they can't really push that out as a deficiency.
Is there anything or any specifics that you know that you could make us aware of that would help retention? It's not always about pay. I know, you look at pay, but there are a lot of other things sometimes that factor into someone's decision to stay or to leave. Anything that you could advise us on?
I don't think so. I think everybody, you have outstanding experts here that's kind of what they do for a living. And I've seen tremendous amount of things. So what do we do? As you've mentioned, pay is usually 3 or 4 on the list of retention things. And the first is to be treated well. And what does that mean? So it means to not be denigrated, to make sure you're respectful. And certainly we hope to strive to do that every moment of every day. And going through the ICU this weekend, it was a horrible weekend, very busy for everybody. And the ICU did great work, as they always do. And so, we might kind of bring donuts in. Something as simple as that. And then when we're on rounds, we educate. And so we do have a cadre of resident nurses as well as new nurses on. And so JPS is very special in that the pathology we see here, the type of very sick trauma patients we see here, you won't see in very many places. And I told our chair chief, Dr. Miller, that when he was interviewing, he came from Vanderbilt, so he's thinking, yeah, right, I'm from Vanderbilt, I'm not going to see anything new. Thank you. Let me know if I say something wrong. And his first week here, he was so excited about the pathology. Since he's here, he can verify that.
Yeah, I'm in the ICU this week. That's why I'm sort of standing here listening to Raj. Well, first of all, sorry to interrupt, but I do want to commend Raj doing an amazing job with our trauma team and passing with flying colors so many times since he's been the trauma medical director.
Thank you. And I agree, the way to retain people is to create this multidisciplinary team that all works together, that everyone has input, we're all valued, we all work together. There's no, I don't own a patient, Dr. Gandhi doesn't own a patient, or Stevenson, we all own them together, and we all do things together. The ICU is, this weekend was crazy. I'm sort of cleaning up for Dr. Gandhi and Dr. Ziegler now. Very sick people, multi-traumas, car wrecks, gunshot wounds, construction accidents, all kinds of things. So we're still the #1 trauma center, and we're going to remain that way by continuing to take really good care of patients, because we can't prevent any other institution from becoming a level 1, but we can always do it really well, and that's what we're going to do. So I was just eavesdropping and listening to Raj, and I have to get back up to the unit. So thank you very much, everybody.
Thank you.
All right.
I have one
Thank you.
question. I know that your number 5 on opportunities is to reduce the patient leaving without being seen, but that was a major discussion at our board retreat too. And so what I would ask is, as y'all are working on that just become a part of reporting back up to quality, so that it will be, we can report it for the full board, okay?
Yes, ma'am.
Thank you.
I have one other for you, Raj. It's sort of a global thing. Is the left without being seen in the emergency room was so good, 3 or 4 years ago, we actually dropped it from the quality indicators that we were looking at the quality committee. Now it needs to go back up for everybody to look at.
Yeah, yeah.
What impact do we see, or do we see a negative or positive impact should Harris become a level 1 trauma?
Yeah, that's a great question. And personally, I believe there will be very little impact because all of the referral patterns have been set, and in trauma, we talk about a hub and spoke, meaning the hub is the big center and it has spokes to all of their little centers. So that hub and spokes model for THR has been set. And it's really with their THR places. With us, we have a bit different spokes because we don't have a group of hospitals that are under us. And so our spokes are to the community places that really don't have a place. So for example, United Regional is out there, Wise Regional. We've actually gone towards Abilene, so we get more and more patients from Abilene. And we've also gotten patients as far as Amarillo. And you may say, well, why is that? The reason that we get the patients from those areas is because nobody else is wanting to take transfers in. They are very busy. And our administration has made it a point that we are a regional center and that we need to help all of the people that need help that have been in very massive traumas. And so that is a huge commitment. Certainly, it's a win-win-win. It's a win for the patients, it's a win for the hospital, and it's a win for taxpayers, which is what we always want. And so we continue to do that. And it takes a huge effort on the part of everyone on the administration, especially the nursing side, to be able to get the manpower to take care of all these extra patients that we get in. So our draw area has increased quite a bit. Amarillo is just one part of it. We get patients from north, we get patients all the way past Mount Pleasant. Last year we got a patient from East Texas because nobody else going through the entire eastern corridor was able to take that patient. And I can tell you that the family of that patient was extremely happy that we took that patient. Great question, thank you.
No.
Any other questions?
Once again, it's a great program that most of the community doesn't know anything about.
Yeah.
Yeah. So, and again, the THR referrals have been set. I think the neighborhood and certainly the far-reaching neighbors that we have also understand the program we have versus other programs. So I think that makes a big difference. So thank you.
My comments on Chuck missing about community doesn't know all of that, but I would say that many also may not understand what level 1 trauma is.
That's what I mean.
Right.
Because it's a system.
Yeah.
It's a big system.
Well, I want to say thank you for the work that you do, and I'm very proud that you are with us. Okay?
Thank you all very much. I'm always grateful to come and speak to you all, and super grateful for all the support I've received over my 15 years here. So I really appreciate you all. Thank you.
I think it should be noted as well that this survey was the 5th consecutive reverification survey with no criteria deficiencies. So that is a testament to something that is really sustainable.
Yeah.
And Dr. Gandhi, Cassie, and the entire team, I think, deserve a tremendous amount of credit and thanks for that incredible record of phenomenal work. So I just want to underscore that because that is astounding. So
I would agree.
And I would concur that Cassie my dyad partner and our entire trauma team is the best system-wide team I have ever worked with. So I would definitely echo that.
Part.
So the nursing side partner, physician side, nursing side.
Okay. I thought it was diet.
Yeah. The triad partner would be our executive team partner.
Old age.
Sound like diet when you say it. That's why we were wondering.
Sorry. So the next thing that we'll be discussing is our Joint Commission certified programs, and Adrian is here to talk about it. I also wanted to give kudos to Elizabeth Rogers, who's the Executive Director for Programs. And before Adrian begins talking, I also wanted to tell you all, I don't think Dr. Duncan would ever mention it, but when we were originally going for certification, we were going to go for level 2 certification, and it was her fearlessness that said, you should just go for level 1. And so we did. So I do appreciate that leadership. So thank you, and I'll turn it over to Adrian.
Welcome.
Welcome.
Hi, this is the first using the microphone. So, good afternoon. My name's Adrienne, and I, like Dr. Gandhi said, am the Patient Blood Management Coordinator. I've been with JPS for almost 10 years. I am a born and raised JPS nurse, and I stepped into the Patient Blood Management Coordinator role in February. Our physician champions for our program are Dr. Gandhi as well as Dr. Johnson. I also have with us our wonderful leader, Elizabeth Rogers, as Dr. Gandhi mentioned, who supports our ongoing PBM efforts, and then Jody Primero, who is our clinical resource specialist for the program. Thank you for allowing me the opportunity to speak with you today and highlight the amazing program that is patient blood management. To give some background on patient blood management before we get started, this program was started as an initiative from Dr. Gandhi many years ago. In 2019, the program was formalized, and now here we are 3 years later celebrating our Joint Commission certification for patient blood management. A few examples of other hospital organizations that have this certification include Johns Hopkins in Baltimore, Maryland, MedStar Georgetown University Medical Center in Washington, D.C., and the Mayo Clinic in Rochester, Minnesota. As with everything we do at JPS, we need to ensure that our program goals are helping to align with our overarching strategic plan, which is guiding us towards our true north, which is our patients. Patient blood management fits into the strategic imperative of setting a new standard for a culture of excellence. So patient blood management fits into this by the ongoing support for good stewardship of blood product utilization and creating a safe, managed environment for all patients, including those that may or may not receive a transfusion. JPS was officially certified for patient blood management on June 21st, 2022. Our survey date was May 6th, and after completion of our action plan items, we were given the certification on June 21st. So the survey was a single-day in-person survey, and it's a dual certification between the Joint Commission and the American Association of Blood Banks. So why is certification important? Certification promotes and validates excellence, it improves processes, it improves patient outcomes, it decreases the risk for error and decreases variation. So certification also recognizes all of the efforts we've done as an organization to establish us as a center of excellence. Not only is this a center of excellence for how we manage blood utilization for our patients, it also establishes us as a center of excellence for those patients in our community that choose to not have a blood transfusion. This gives our community members a peace of mind knowing that we will support and provide alternatives to guide their plan of care without the use of blood products. Overall, we had a great initial survey. The goal from the surveyor as we moved throughout the course of the day was to highlight and celebrate all of the work we have done as an organization to support our patient blood management efforts. So the locations that the surveyor had the opportunity to visit were women's services, emergency and trauma services, perioperative services, P4, our blood bank, our clinical decision unit, and then we finished our day with some closed chart review. So over the course of the day, with each stop that we made, every team member was engaged, excited, and willing to highlight all of the work we do to support the patient blood management program for our patients. At the end of the survey, the strengths identified by the surveyor include the inclusive, collaborative team environment that we have at JPS, the rules of the road. She said that these needed to be everywhere, even on airplanes. The pre-surgical optimization clinic and the work that this team does to prepare our patients for their elective procedures. The NICU blood conservation strategies, our nurse-driven transfusion safety work group, our preoperative huddle, which includes a focus on blood conservation techniques prior to the patient entering the OR. Our use of ultrasound and viscoelastic testing, a QR code that we have set up for education, and finally our therapy dogs. She had the opportunity to meet Morgan while on our way to...
Expand a little on the therapy dog.
So our volunteer services, we have therapy dogs that come in and they visit with our patients, they visit with our staff, and they just bring a lot of joy to everyone.
I understand that. I just wondered why that was considered a strength with the blood management.
So what happened was, as they were going around, one of the dogs came, and immediately they were surrounded
Yes.
by staff. And so that made a huge impression on the surveyor that, you know, we as I was saying before, we're respectful, but we also understand there's a lot to the staff, and we're going through quite a bit. And so having the therapy dogs is therapy for the patients, but it's equally therapy for our staff. And that was really the whole part of the strength, was that we do take care of our own.
Yes, so we were heading towards perioperative services, just getting off the elevators. It's a very busy section of the hospital. And so the dogs came through one door, we came through another door, a group of our perioperative nurses came through, and it was like a meeting of the minds right in the middle, and everybody just took a minute. Even the surveyor got down to pet Morgan. And she made the comment that she had been on the road for a while, and she has dogs at home, and she missed them so much. So it was just a perfect addition to the day. So,
That's a good staging event.
yes.
Yeah, so, yeah, we've planned it. So for the next
Yes.
survey, yes, we'll have it staged,
Yes.
a spontaneously staged area.
So at the end of the survey, the one opportunity that was identified was the inclusion of our contracted perfusion team members in our organizational patient blood management education. Dr. Gandhi, do you want to discuss our perfusion team members and how they...
Sure. So we actually have a contracted service for our cell salvage. What is that? Cell saver. So what we do is, let's say we have a case and we'll suction out blood, and that blood will go into a container that then that blood and those blood cells get washed 3 times, get put through a special filter, and then can be transfused back to the patient. So those operations that somebody may lose 300 cc's or roughly 10 ounces of blood or more will have the cell saver set up. And so the first thing I always think of is, well, how much is that going to cost? And so 1 unit of blood, and this is old because they have raised the price. Our cost used to be $205. It's more now. One cell saver circuit is $100. So just by saving 1 unit of blood, we've saved ourselves $100 per patient. So it's those kinds of, again, win-win-wins that we were able to do with this program. So, and that perfusion team did not get any education on our patient blood management center of excellence. And so that's what they asked us to do, which is a very simple thing. And Adrian has already kind of worked on getting that all set up.
So we made contact with our perfusion team leader and discussed the avenues that they have for education. Since they're coming into our organization, they don't have our learning platform that we have for all of our staff. And so we took our education that we give to all of our nurses and converted it into a way that was manageable for them and sent it to their team lead, and he helped to facilitate and incorporate that education. So moving forward, anytime we have a new perfusion team member that comes in, we will make sure that they receive that patient blood management education. They're doing the work, we just needed to make that connection so that they understood our values and how they impact our organization. It was a great day. So what are our next steps? So we've established ourselves as a center of excellence, so how can we continue to move forward? So expanding and growing our use of CellSaver, Dr. Gandhi just mentioned that. So we've created a really strong partnership between our PBM team and our OR team, and we're collaborating monthly to review our CellSaver use and continue to see how we can grow it. It sounds like our trauma team is doing some good work with making sure that we have CellSaver set up for all of our traumas coming into the OR. And so looking at our processes that we have to support the ongoing use. Continuing to support and create awareness around single unit blood product ordering when possible. So there is the phrase, why give two when one will do? So looking at how are we ordering our blood products? Are we giving 1 unit, 2 unit, 3 unit, and identifying and drilling down on when we're ordering more than maybe we need to, and working with those teams and those providers to see, did we need it? Could we have given one? So that we continue to work on good stewardship of our resources. On average, a patient's length of stay increases by about 10 days if they receive a blood product while they're in-house. And so looking at, are there other alternatives? Yes. So one of the metrics that our program is looking at is how does our length of stay impacted by the use of blood product? And so when we're looking at it month to month, it's usually around 10.4-ish days, so about 10 additional days.
Is that really because of the use of blood product, or because those patients are more critically ill that wind up receiving the blood product?
Yeah, that's a great question. So it's probably a combination. However, we know that blood is immunosuppressive, meaning it causes our immune system to not work as well as it would. And so we're at higher risk for infection. In a trauma patient, if a trauma patient gets 10 units of blood or more, it's 100% that they will get a pneumonia. And again, it's the same idea. We give blood when our hemoglobins go down over time. People get, they feel funny about not giving blood because, our hemoglobin is supposed to be 10 to 15. And so if it gets below, we start getting antsy. And so we've done a lot of education that we really need to look at the patient and not treat a number. And that's huge because the thought process has always been, when I was in the ICU and I had hair, we transfused to a hemoglobin of 10. And then as I lost more and more hair, our hemoglobins went down to 8. And now it's 7 as I have no hair.
So what is the correlation between your hair and the hemoglobin?
I'm still working on
patient?
that part.
I'm trying to make that connection there. Forgive me.
Yeah.
Say again, John? Okay, all right.
So the whole idea is education and making sure people understand that we actually take blood from our patients every day. And we take enough that by the end of a 7-day period, we've probably taken off a unit of blood. And so if we can start with that and really be very careful about not ordering labs every day. And that was one thing, that was one of the first things we did is stop the ability to order daily labs. And that was huge to decrease the number of units of blood that we transfused.
Have we ever looked at how much we actually need to run those tests versus how much is getting drawn? Because some of those vials are pretty big, and you may need this much, and you get this much. And
yeah, that's a great question.
Times 10 is like, okay, well.
So Dr. Miles and I have had that conversation before.
The laboratory has always initiated a blood production strategy, so we use the smallest tube possible for the tests that were ordered.
Yep, exactly. Thank you. And then with our blood declination order set, meaning if people decline blood, that order set goes to even pediatric tubes. And like smaller things are more expensive. Pediatric tubes are a lot more expensive than the regular sized tubes. So, that order set helps our providers across to be able to, do one simple order set, and that takes care of all those little details. They don't have to worry about iron and how much and all that. It's all in the order set.
And so to piggyback off of the blood declination order set, so one of our continued areas of focus is enhancing our processes for our blood declination patients. So currently what we do now is Jody, in the back there, she reviews all of our patients that may be a blood declination patient. So they have been indicated in the chart that they may not want to receive blood products. So when we drill down and we review the chart and see if they could potentially be a blood declination patient, she will go and visit that patient. And we have some education materials that we can provide to them and have a discussion about what their wishes are. Are they okay to receive blood products? Maybe it was just a miscommunication about the question. Or if they are truly a blood declination patient, then she provides information, lets them know that we are here to support them through their plan of care while they're in the hospital. She'll put a note in the chart indicating that they are a blood declination patient. She'll leave a reminder to the provider to consider utilizing the blood declination order set, and then also advocate for use of our blood declination consent that we can have for these patients. And so as we're doing this, we're learning from them and seeing what information they can share, and then that helps us to guide how we, through this process, and how we can continue to develop it. So, and then finally, establishing some baseline metrics to support our outpatient optimization clinic. So I've realized through this position that our optimization clinic does some amazing things. They are visiting with our patients to make sure that they are medically optimized prior to going into the OR, not just from an anemia standpoint, but from diabetes management, blood pressure, weight reduction, all of those kinds of things. And so we have partnered with them to look at what are they doing for anemia management prior to sending into the OR. And so looking at what they're looking at, trying to pull some metrics so we can build that program to support the success of it is kind of one of my next goals and our next goal for the program. Our next recertification, we will be surveyed again in 2 years, so it'll be approximately in May of 2024. And then just to leave you with a final note, we mentioned a few of the organizations across the country that have this patient blood management certification. And overall, we learned that JPS is one of 9 organizations across the country with the patient blood management certification. And we are actually the first program in Texas to be certified. So we are definitely setting a foundation for being patient blood management centers of excellence. So.
Outstanding work.
Yeah.
Thank you. And one other thing that's been a byproduct is education of our physicians. So there's been things that I've been touting for 5 years, and now there's more and more material out there. And so before we didn't use cell saver in cancer operations, and now we know that that's safe to do. And so our physicians are learning these kind of new information that they can use for better outcomes of our patients.
Are we educating our younger intern and resident physicians on this? Because many times the orders that get written late at night for the labs to be drawn in the next morning are from them.
Excellent, and that's absolutely true. So in our orientation this past late June, we did have patient blood management as part of the orientation for our interns.
So one of the new things that we did establish was we have incorporated the patient blood management CBL that was assigned to all of our nursing. We've worked with our resident teams to have that given to all of them. So they've received a CBL for it. We've also incorporated a PowerPoint into a lot of their booklet information, and then just ongoing education.
All right.
One question, Dr. Gundy, it just clicked on me. A gunshot victim, wound victim, since it appears to be an epidemic in our town right now.
Yes.
Does trauma level 1 trauma get many of those victims?
Yes. Yeah. Well, over the weekend, we got quite a few.
Yeah, right. That's what clicked on me when you said that.
Yeah. Yesterday, I think we had 3, if I'm not mistaken. Yes, we do, unfortunately. And we do work with one of the things that we're always trying to do is And sorry for all the financial folks. We try and put ourselves out of business. We all know that we will never go out of business, but that's the outreach, education, and most importantly, prevention of trauma. And so that's one of the areas that we do work with to prevent violence, prevent assault. And so we have different areas for the assault with deadly weapons, as you've mentioned. Working with our community outreach people in the police department and other areas. We also do intimate partner violence, which can range from strangulation to severe assault as well, to penetrating assault. So we do work with all of our community resources to try and prevent as much as we can. Unfortunately, a national trend over the last, since basically COVID started in March of 2020, has been an increase in penetrating trauma. So whereas our penetrating trauma was 12 to 15%, now it's about 20 to 22%. So it has increased substantially. And that, again, is a national trend.
Any other questions? Well, congratulations. Well done.
Thank you very much. Thank you all.
Next, we have Dr. Stevenson, Infection Prevention Plan. Welcome back.
Once again, I thank the committee for the opportunity to present this. This is an annual regulatory requirement that we put forward an infection prevention plan for the year, and that we also evaluate the outcomes of the previous year's plan. So you have the complete plan and evaluation in your packet, I believe. In the interest of making something that is a little bit more presentable, we have some summary slides which we'll go through, and then we will need approval for this plan for the year. So we ambitiously said we wanted to decrease most of our areas of infection by at least 10% for the year of 2021. This ambition would have been made at the end of 2020, going into 2021. CLABSI did not decrease. Okay. Can we make sure that the board members get the complete plan? I think there should be copies. I thought we had discussed that. Okay, great. Thank you. All right, we'll make sure you have it. Thank you. I'm sorry about that. We sought to decrease CLABSI by 10%. This did not occur. 2021 turned out to be a very rough year for CLABSI, largely because of the winter surge of COVID, followed by the Delta surge of COVID. So those two things made it very difficult to achieve that, and we had a rough year in CLABSI, and we've discussed that in this committee previously. Partially met, we implemented our COVID-19 procedure. That was significantly successfully implemented. Greater than 90% compliance with isolation rounds was not met because there were so many patients on isolation. You just could not get to all of them all the time. Decrease of surgical site infection by at least 10%. This was observed in all targeted procedures except for C-sections, where we've been tracking and trying to drive down the rates of superficial surgical site infections for CLABSI, for C-section. These are not, usually life-threatening, but they are something that make, the early postpartum period pretty darn not great for our patients. And so we put a lot of focus around that, and that remains an area of focus. We are doing better this year, though, so that those efforts are beginning to pay off, and so we're really pleased about that. So that's good news. And then not all of our procedures and bundles were finalized by the end of the year, but now again, that's something we've caught up with, as well as we've been able to breathe out of the heaviness of COVID to some degree in this current year. We met greater than 90% of compliance on infection prevention tracers for high-level disinfection, sterile processing, and sterilization. High-level disinfection, sorry. That's what we were talking about with the probes committee and stuff like that, where we take things that are, that are not capable of being sterilized, but you put them through a process that gets them substantially clean. The classic example is an endoscope. You can't sterilize the endoscope typically, but you put it through that processor in those scope processing rooms and so on. So here are our goals for this year. Improve compliance to HLD practices in the ICU. So this was sort of the last area where we rolled out high-level disinfection for the ultrasound probes that are used primarily for line placements in the ICU, and that is going along very well. Improve phlebotomist adherence to standard and transmission-based precautions. Improve processes at our outpatient laboratory locations. And so we want to see greater than 90% compliance on tracers and audits. We want to reduce CLABSI by enhancing prevention bundles. We definitely want to see an SIR of less than 1. We've been above 1 now for 2 consecutive years, which is really unusual for us. We haven't seen numbers like that in a long time, and of course, heavily COVID impacted. And we want to see a greater than 90% compliance on all central line audits. Improve compliance with PPE use as an element of transmission-based precautions. We want rounding tracers. We want to improve staff knowledge of hand hygiene as an element of infection prevention. We want to see greater than 65% compliance for hand hygiene and infection prevention tracers, not the secret shopper. We've discussed this previously, that there is a discrepancy between what is, when we do a verification audit with the infection prevention team, we see different numbers than we've seen with the secret shopper data, and we've discussed that here previously. Going over to the next slide, we want to improve staff knowledge on standard precautions as an element of infection prevention. So this will be greater than 90% compliance for infection prevention tracers. This is obviously critical for continuous readiness for Joint Commission. We want to improve compliance of high-level disinfection practices in OB/GYN areas. So again, greater than 90% on the infection prevention tracers. We want to establish a robust process for responding to an influx of infectious patients. So we've updated the IC 201 infectious disease influx plan and updated the elements of performance section with specifics to biologicals and infectious disease. We're implementing a crisis standard of care to address spread of infection during disasters. And finally, I believe this is the last one, reduce the number of sharps, injuries, and needle sticks. We want to see at least a 10% reduction in sharps injuries during this year. So we will be back next year again when we have completed the evaluation of the 2022 plan, and we'll let you know how we did. But in the meantime, we ask your approval for the 2022 plan, and those being the major goals of it. And if we need to defer, we sort of can, except that if we go to the next quality board, we won't have it done during this year, and so we'll miss compliance on it. So my apologies for that not being in your packet.
That was my question, is when do you have to have this done by?
End of fiscal.
Okay, end of fiscal 2022?
Yep.
All right.
The 90% and 90%, the goal is to be at 90%?
Or better.
Or better.
Or better.
Where are we now?
So we are not at 90%. I can't quote it to you off the top of my head, though. I apologize.
Yeah, it would just
be helpful to know
how far.
If we put it on as a goal, I can tell you we aren't there now. So that's best I can tell you. And I'm sorry I don't have that number off the top of my head.
Is there anyone not okay approving it at this meeting?
I'm just not comfortable approving something that I haven't had a chance to read. If
Okay.
you're asking me to look at your goals, that's one thing, but this is the policy, and we're gonna have a board meeting that will give us an opportunity at least
Yes.
to look at it.
I'm fine with that. It just has to be done during this fiscal year, so I'll leave it to your judgment to figure out when that ought to occur.
End of September. Okay, so we have to have it by end of September.
Yeah.
Okay, so,
Probably have to be outside.
But that would still be in time enough for his
Yeah,
fiscal year.
you should be able to get it done.
Okay, all right, okay.
Okay.
can we approve it by?
The reason I asked that is because it would just, I would be comfortable knowing
Okay, but that would be for the September meeting.
projected where we are to get into 90%.
Sure.
To find out, is it a realistic, attainable
Yeah.
reach?
Well, part of this, some of the goals are stretches for us. I mean, we want to challenge ourselves. I mean, the greater than 90% would be what we would consider acceptable, actually, for these things. Our staff should know these things. We should have HLD practices at a high level, and above 90% is reasonable. So some of this is where we need to be, regardless of whether or not we end up attaining it. That's on us if we don't get it. We should be getting these things. You know what I'm saying? So we need it. Yeah.
I do understand that. You kind of need to know where you are.
Yeah. No, I'm fine with that, and I can
All
get
right.
you that information.
Okay, I'd appreciate that.
I'll get you the 2021 performance.
Right.
So we can take time to review it, and we can approve it by email to go onto consent agenda for the September board meeting.
Yes. Yeah. Yeah, I know we can put it on our September meeting. That's when
Right.
you're going to be reporting out, so we'll be ready.
Yeah, we can all approve it by email for consent agenda, though.
Okay.
For the September meeting. So we're going to take time to review it and then do an email approval, and then it can go on to consent agenda for the September meeting.
Yeah.
And that'll meet our goal, correct, Dr. Stevenson?
Yeah, that
As long
would be
as-
great.
Okay.
Okay.
All right, any other questions? All right, let's move on then to True North, our patients, patient experience. And Laura? Welcome.
Good afternoon. Thank you for having me today. I always appreciate the time to be with all of you. Yeah. We're not moving. I don't. Oh, there it goes. Okay, okay, thank you very much. Our organizational goal for this year and for our annual incentive plan encompassed 6 different areas and was a weighted average of those 6 areas. So what you're seeing on the right-hand side of this slide is that weighted average, which is 74.5, which is achieving stretch of the weighted average between our inpatient surveys, our outpatient surveys, our clinics, our emergency department, and our behavioral health inpatient and outpatient surveys that go out to our patients, measuring their experience. All of the areas are improving and have increased in the percentage of top box scores over last year, with the exception of the emergency department, and we'll talk about that particular area in detail in just a moment. Our area of focus is our developmental action plans for each of our specific areas. So for all of the 6 areas, plus the rest of the organization, we actually develop action plans based on specific units or specific areas. And we do that by looking at all of the scores that come in, and then there's a statistical analysis that is completed by our vendor, which is Press Ganey at this time. And thank you. And the statistical analysis actually shows us where our focus should be and on what our focus should be. And we work with all of our teams across the network so that they understand what is most important to our patients. And then we develop interventions based on what that data analysis is telling us. Additionally, we do real-time observations and coaching. So on each of the units and in our clinics, we actually send a representative and we observe what's happening so that we can ensure that the intervention is actually taking place and that we do achieve high accountability levels on that in order to move results. Service recovery training has been offered on a monthly basis for the last several months. We've put, I think, about 400 people through that training already, and we will continue to offer that training specifically for areas as requested, as well as the network-wide training that we offer on a monthly basis. Service recovery, it's when something doesn't go right, how do we make it as good as we can for our patient? And so we utilize here a model that we refer to as the ACT model, ACT, which is we apologize for what's happened in whatever way we need to do that. We correct it, and then we thank the patient and the family for sharing the information with us so that we can become better. On our inpatient side, these are some of the dimensions that are measured through our HCAP survey, which is a regulated survey through the Centers for Medicare and Medicaid Services. And so when you look at our N size is the first column, our top box score, which is the patients who have rated us at the very top answer on the survey, and then the third column shows our percentile ranking. So in most of these cases, in most of these domains, we are performing at the highest levels across the country. The one exception to that is care transitions, which is nationally a difficult domain to move. And so we have actually established a couple of committees that are focused on that, whether it's from the throughput side or from the appointment and scheduling side. And so in just a moment, I'll show you what our access looks like over the course of the last few months as we've put those committees in play. And we are seeing an improvement at this point in that domain, but it's, again, a very low performing area for us. And that encompasses 3 questions. One, and they're really around when the patient is discharged from the hospital, do they know what to do with their care? Our outpatient surgery, yeah, more question? You have a question?
So is the survey saying that we didn't do a good job educating them on what to do, or?
Well, it measures 3 different areas. One is, did we meet the patient and their caregiver's preferences on what the next level of care is? So typically in a clinic environment, whether it's a primary care physician or specialty care. One is around discharge instructions, and the other is around medications. And so those are the 3 specific areas that we cover. So they really do have to do with discharge, and then when the patient gets home, do they know what to do at that time?
Are patients discharged with an appointment already made for them, or are they given information they have to go make an appointment?
Both. And so what we've been working on, in fact, one of the action steps that we've taken is actually opening up appointments that are available 30 days out. That used to be only 2 weeks. And so now we do have 30-day out appointments, because sometimes 2 weeks is too soon. And so we might discharge that patient home and say, call this number for an appointment, whereas now we can do that in advance of them discharging from the hospital.
Are we looking at anything regarding how easy it is to call those numbers
Yes.
and get through and actually make an appointment?
Yes, and that's the other side of the committee work that's happening is on the appointment scheduling. And so I'll show you how our access questions are, how our patients are rating those at this point in time in just a moment. But yes, we do look at that. So we look at abandonment rate, we look at time to answer, and then there's an entire committee that is focused on MyChart scheduling as well, so that we don't have to have a patient call. You know, they could do it on their own, and all of those things are part of our action plan as we move forward.
Is this what time frame is this inpatient data? Is it
This
3
year.
months? Just this, the whole year?
This year. Mhm.
Okay, all right.
Laura,
Yes,
not to belabor this, but I want to go back to the transition.
sure.
If I'm a patient and I'm leaving the hospital, on the aftercare instructions, are you talking to me or are you talking to a relative or that's with me in being discharged?
Both. And additionally, what we have started is having our care ambassadors round on all patients who are discharging from the hospital, and they're asking specific questions related to understanding of what the discharge instructions are. So that would be to the patient and/or a family member who might be in the room.
The reason I ask those questions is when I look at that 48.5, I think back to, I know this one guy who says, yeah, I got it.
Yeah.
And then when he gets home, what is he? That's me, you know, so.
Yeah. It's confusing.
Well, paying attention and
Yep.
you just want to get out.
Stand in
Yeah.
you know?
No, that's true. When you're sick, you don't
Yeah.
receive the
It's true.
information as well.
Yeah, it's very true.
What is the process for which patients will get their medications at discharge? Is it sent to a JPS pharmacy? They have to go pick it up, or do we have medications that are delivered to them as they're discharged? Or?
We do. We have a couple of pilots, units that are doing what we call meds to beds. And so those our goal is to increase the meds to beds program to all units within the hospital. Additionally, if we have a patient who goes to the discharge unit, then we would bring medications into them as well. Our ultimate goal would be that they receive those meds before they actually leave our facility.
I'm sure that there are instances when people don't receive their meds and they
Correct.
wind up admitted back to the hospital again.
Yeah. That's what we're trying to avoid
Right.
by doing it this way, for sure.
That's the one for me that is the biggest leap that you have to make, is they're not doing good handoff and dismissal. How does that affect the 30-day readmission rate?
Yeah.
It's especially diabetics, the ones that we look at.
Yeah.
This is an awful low.
It is.
Diabetics, heart failure, there's all kinds of diagnoses that if they don't get their meds fairly quickly, they could wind up back in the
Yeah.
hospital again.
This domain is low nationally. So even for us, for instance, when we look at what's the top of the country, it's barely over 50%. And I think we need to do better than that. So we have a lot of people who are working very diligently in these two committees, two sides. One is, through the throughput piece, but then the other is the appointment scheduling and access piece. And because we believe it's that important.
I would caution us on every patient getting their medicine to the bedside. Some of them come in with those medicines and don't really need them. And so sometimes we hold them here to make sure they get those medicine, they already have them. That should be a part of that assessment.
Yes.
That says, or, listen, I might not want to get my medicine here. Where can you call it? It just shouldn't be here because they can go other places. So I would think we would look at that a little bit closer because sometimes we create the problem of them not getting their medicine because we've ordered it here and they can get it somewhere else.
Yeah, I believe they are. That's a great point. And I do believe they are offering those options, but we'll make sure as we work with the pharmacy on that we're doing that. That's a good point.
Yeah, I would ask you to go back and look at that.
Yep.
The people that's going around, what questions are they really asking?
Yes, absolutely.
Okay.
Outpatient surgery, this is, you can see our top box scores here are very high. And when we rank ourselves nationally, our percentile ranking is lower than what we would expect it to be. And so there is action planning also occurring with our OR leadership. And initially what we found was the challenge we were having was on the front end, and there had been some personnel changes, and we had either vacancies or we had new people in those positions with registration and that sort of thing. And so as we continue to look at this, we will continue to look at the communication faculties and also the facilities and personal treatment as well as discharge from the OR to ensure that we're doing all that we can as we release our patients from our outpatient surgery areas. And just as a reminder, this actually will become publicly reported information in 2024. And so we are currently using the survey that CMS will regulate and working to action plan on that, but that's fairly new for us.
Okay. Help me understand,
Sure.
top box scores that's the highest that you can give.
Correct.
And then the percentile ranking is so low. What, if you're at
Yeah.
90 point,
Yeah.
what do I have to be, 100 to be at the?
Very high nationally, yes.
Okay.
Yes.
All right, okay.
It's
I
been
just
that
didn't
way.
understand that.
Yeah, it's
Okay.
been that way. So I think I started this work about 20-some years ago, and it's been that way ever since then. High top box score in surgery, but the percentile ranking is really difficult to achieve.
Yeah. On the discharge, what are they looking for when you're saying questions on the discharge?
I would have to get those. I don't know those off the top of my head.
Yeah, okay. I will tell you that my one experience with the discharge, you give me a number to call.
Yeah.
And I call it, and they tell me to go to the ER. I am super upset at that point.
Yeah, absolutely.
And so I don't know if we've changed that, but on your discharge instructions, you tell me who to call,
Yeah.
and it's not 5 o'clock, and you still send me to the ER.
Yeah.
So,
Yeah.
and that's not when I was here. That's when my sister had a procedure not too
Yes.
long ago.
Yes.
Okay.
When moving on to our clinics, this is, you asked about the access questions. So the ease of contacting and the ease of scheduling appointments are the two questions that we ask related to access on our survey. And both of those have improved this year over last year. And then in addition, would recommend is kind of the overall question that we ask related to the clinics. And you can see the improvement from Q3 to Q3 of last year to Q4 of this year.
So our scale on the side of access to care goes from 52 to 70? What exactly?
Yeah.
As far as the access to care, top box score,
So, but would the top box be 100%, or are we cutting
Yeah.
it at 70?
correct.
So it should go 0 to 100?
If it
would be
went
the
0
score?
to 100, yes, that's
That's
correct.
the full range?
Percentage, yes. Percentage of patients that rate us on that top answer choice on the survey, which is the only answer choice that we get credit for.
Okay.
Okay.
And remind me on this particular one, at what point in time during their visit that they're being surveyed? It's after?
It's after. And we've done quite a few things here. So we've extended some hours for our ancillary departments, so for the lab and the pharmacy locations. We expanded locations for those as well. We also have been doing quite a bit of work on the in baskets for our providers and our physicians in MyChart. So those are being answered. We have a couple of pilots going on, and the actions and outcomes from that have been quite phenomenal. And so as a message comes in from a patient, we are responding to those messages in a very timely manner to be able to make sure that the patient receives the care that they need.
What is timely? Define timely to me.
It varies. So within 72 hours has been what the standard has been set, except for the fact that with these pilot areas, we are responding within more of a 24-hour range. So we do think we have the right formula, if you will, to be able to bring that out to the other clinics. But that, there has been quite a bit of work that's been happening with that, as well as pre-registration and referral work as well. And then we are moving to self-scheduling also. Yeah.
You're focusing on two clinics, right? That's what you're telling me?
No, there is specialty clinics, and there's a grouping of them.
Okay. If you put in a request an appointment through My Choice, is there a review of that? Is it some key comes up so that somebody will know it?
So if you send a message to your physician through MyChart, we do have someone reviewing those messages. So 72 hours right now has been the standard for quite some time for those to be responded to. But we have a group of clinics that we are doing a pilot to get that sooner. So and in that message, it would say, the patient generally says what they're looking for, and then when we contact the patient back, we would take care of that request.
I'm not sure that one is working in 72.
It's brand new, yeah.
Okay.
Yeah.
No,
Well, the 72 is not, so, and they do measure that. I don't have that information.
I would just say it this way, that I end up doing a lot of My Choice for my sister and for some other folks in my community, and I do use that to send it. So on that, I'm not sure that they were ever meeting the 72. Okay.
Behavioral health, again, we've got different domains that we measure, and for our behavioral health patient experience, we've seen improvement in every domain from last year. Doing a phenomenal job. The emergency department, by the way, I should say this. What you're seeing in our results this year are not what we're seeing nationally. So when we talk with Press-Ganey, our vendor, and they give us national trends, there's about a 45-degree decline nationally. And that's not what we're experiencing you can see even just our clinics and the inpatient as well as our emergency department, that is not what we're experiencing, or our behavioral health areas. And so I do have to commend our teams for the work that they're doing. You heard a little earlier today that our volumes have been incredibly high in the emergency department. The room availability is limited, and the acuity levels and volumes have been higher than we've ever seen before. And through all of that, we are seeing an increase in the way patients are experiencing their care. So we do continue to work with our emergency department on a monthly basis through, and again, you heard earlier, some leadership changes, high volumes. We had 118,000 patients through last year, so it's a large number of patients. And so we are looking at two specific metrics in the ER, one because it's an overall rating of care, and the other because it is the key driver that we know is most important to patients, and we're not performing where we need to perform in their eyes. And so when you look at the right-hand side of this slide, in staff worked together for care, this is the area that patients are asking us to do better in. And so we are improving in that area, but we still have work to do, obviously. And this is top box score.
When you say that nationally in the emergency room, the scores are going down, were they higher than ours in the beginning?
Well, I would have to look at that,
Okay.
frankly. I can tell you, when I do a distribution of scores across the emergency department and just overall rating, we have most of our scores, so 7 or 8% are falling in that very good space, and then another 23% are falling in good. So the majority of our scores are good or very good, and we see very few in the fair poor or very poor area. So our challenge in the emergency department is really to make sure that we are taking an experience that for most patients, not all, right, we've got some exceptions for sure, is a good experience and make it a very good experience. And what we're finding is, depending on the number of hours that a patient waits, of course, that number changes significantly. And so we have actually adopted some action steps where we have a lot of rounding and communication that's happening in the front area. And so our care ambassadors, our leadership team in the emergency department are really owning that that front area and making sure that we're communicating effectively with our patients while they're waiting. And that's a new action step as of the last month or so. And so we're doing the best that we can to make sure that we're updating them with comfort rounds, blankets if they need those, et cetera. Yeah.
Yeah, I hear you. I'm saying, question is, when you go into a store or supermarket, restaurant or whatever, they're saying, excuse the wait time is extremely longer due to staff shortage. So are we seeking to try to convey that to those who come into the emergency?
Yeah. That's actually when we do rounding in that front area, that's what we're talking about, is what might the wait time be. We thank them. We do kind of clinical checks with them as well to ensure that that they are, we're checking vitals and that kind of thing while they're out there. And so the emergency department leadership actually has someone 24 hours that sort of owns that area now. And and then we have a care ambassador who sits at the information desk, and that person is owning that area as well. So if they start to see that there's been an extended length of time for waits, or we feel like they're sort of monitoring that area to make sure that if we have questions or we have someone who needs some additional assistance, that they're going back and getting someone who can come out and give those updates.
And that's 24/7?
24/7.
And when did you implement that?
A couple of weeks ago.
Oh, okay. All right. Okay.
Yes.
Hey, Laura.
Yeah.
Last time you were here, we talked about the committees and committee members on the different teams and putting individuals from frontline staff.
Yes.
On the patient experience committee. Has that happened? Or I heard you talk about several different committees.
Yeah, they are a diverse group of people from across the network, and the committees are quite large, so they have a variety of different ages, ethnic groups, etc.
Yeah, it was not diverse last time, so that's why I was trying.
Well, you were asking about the patient experience team. The patient experience team is a very small team, and we have one vacancy right now. Outside of that, those positions have been filled, and they have not adjusted since the last time we spoke. Those folks have been in those positions for periods of time.
Not the team itself. I remember it was a committee of all the department heads and
the executive
individuals
steering team. Yes.
Yeah.
Yes. So sorry. Yes.
Yeah, and we had, there was no kind of frontline or individuals who were
Yes.
talking to that particular patient experience. So
Yes.
Had that changed, or
Yes.
is that still? Okay.
Yes. Yes, thank you. Other questions?
Any other questions? No? All right. Thank you, Laura.
Thank you.
Next is the PSI 90 and quality scorecard. Dr. Stevenson, which I think he stepped out. Okay. So next item then being the consider quality matters regarding or requiring committee actions and/or approval. Jill? Welcome.
Hello, good afternoon. I have 3 policies today that I'm presenting to you for your approval. First one is Nursing 200. This is our assignment of patient care policy. This policy was due for renewal with no content changes.
We can take them at one at the end if everybody's okay with
Okay,
it.
then I move approval. That was just minimal change on that.
Are we going to do them all as one? Are we
Yeah, I
going to
thought
do
you
it?
were going to let her roll. Oh, okay.
Did you-
Hell, I thought that was
We can do either one that you
at a time,
want.
so I
keep
moved
going.
on. Go ahead.
I can keep going.
Okay.
We have PC 1100, our continuum of care plan policy. This again is due for renewal with no content changes. And then finally, our provision of care 1600, sexual assault services policy. This policy is being renewed with one to reflect a recent law update.
Yeah.
Okay.
Okay.
Seems to be pretty minor changes or changes required by recent legislative updates. So
Right. So move approval of all 3
move
policies.
approval of all 3. I have a motion to move approval. Do I have a second? I have a second. All in favor indicate by aye. Aye. Any opposed? Okay, no one opposed.
Thank you.
Thank you. We can jump back to the PSI 90 and quality scorecard. Dr. Stevenson?
Sorry about that, I just got freezing cold back here, and I needed something to warm me up, so my apologies for skipping out.
Welcome back.
Well, thank you. So the PSI 90 continues to be an area of some challenge, although I will say, and you'll see the slide that sort of shows we're finally kind of moving in the right direction, at least globally, that we're finally coming out of our COVID doldrums in this measure, or beginning to, with some great effort, particularly some terrific effort around pressure injuries. You know, this area has been an area of, it's been on fire really throughout COVID, and you can see finally in May and June of this year, we only had 1 pressure injury in each of those months. So we would like to have 0. That would be a more appropriate number for a month, but the fact that we've come down to 1 from the high numbers that we had seen in the earlier part of the fiscal year is reassuring that, you know, our teams are beginning to snap back and get things where they need to be. I really want to give a tremendous amount of credit to our nursing teams and Elizabeth Rogers, who was here earlier, and the leadership that she and the wound care team have shown to start driving this in the right direction, and that's really very, very reassuring. Perioperative DVT and PE remains somewhat of a challenge, you know, but I think on the whole that has also been showing areas of some significant improvement as well. Going on to the next slide, you can see this month-to-month change, so you can see where we started out the year, and we really are finally now moving in the right direction. Finally, we had a month in May where we finally performed, you know, sort of where we were pre-pandemic for at least a month. July is looking a little better as well, so I'm hopeful that this will continue on through the rest of the fiscal year, and then into next year, we'll see us getting back to where we typically are for this measure. Which was, you know, as you recall, you know, even better than 0.9 at our very best. And so we want to see it get back to there very quickly. And these are just year-to-year comparisons of the numbers of different things. So, so you can see that pressure injury number was very challenging in 2021 and is, you know, yet even bigger in 2022, and we remember the sources of a lot of this, you know, had to do with the major staff disruptions we saw in the first and second quarters of this year. So into the rest of this quality scorecard, this will be your 3rd visit to the left without being seen number in the last couple of weeks. As has been mentioned by Dr. Gandhi, this is an area of major work. Really, ever since the trauma survey went, they've been putting together plans and executing them to try to address this number. Of course, this isn't the only really important number in the ED because, if you simply, put a provider out front and make sure everybody gets a medical screening examination within minutes of getting here, although there's major benefits to that in terms of knowing who's really sick and not sick. So that is a good thing to do all in of itself. But if you then, if they then have to sit there 5 hours to wait for their CT scan and they get frustrated and leave without completing treatment, it's better, but it's not all the way where it needs to be, right? You want to make sure that really every patient feels respected, comfortable, and ready to complete their treatment. So, but you can certainly push, by doing, various tactics, you can push them from this box into this box. So from the left of that being seen to the elopement or AMA number, and we don't really want to see that. It's got to be a comprehensive solution where you get all those things done. Yes, ma'am.
Let me make sure I understand your report. If I'm looking at the report, the CMS national benchmark, that's what, are we comparing ourselves to that? And then we have our target next to it, right?
Correct.
Is that what I'm looking at?
Correct.
But that is the benchmark that CMS have put for all hospitals, or is that just teaching hospitals?
All hospitals.
All hospitals. Oh, okay.
Hospitals.
Got that.
Yeah.
Okay.
And also not, all hospitals across the board. So even places that,
Right.
have very low numbers. So low numbers of visits.
Okay. All right.
Okay.
Dr. Stevens,
Yes, sir.
well, one other question, and this might go back to Laura's report. Let's say a person comes into emergency and a CT scan has to be performed. Does that patient, or is that patient informed how long it takes to do the CT scan, read it, and get it back, or they just know that a CT scan was done and you got to wait till the doctor comes in and tell you the reading of it?
So I can't answer that directly. I'm sorry. I don't know. I mean, when we order CT scans in the emergency department, I can speak for myself that we do tell them that's what we need. Now, I have to say actually that getting a CT scan here is not a drawn-out process. And even more impressive actually is that our radiology group has committed to reading all CT scans within 15 minutes of completion, which is an astoundingly good number, actually.
Well, I'm sorry. I was only using that as an example of CT, but I guess I'm asking in reference to any type of
test.
Whatever that X-ray is, whatever.
Yeah.
I just think back to just me having to be there or with a member, and they said, well, we're going to do this X-ray or do whatever that is. Are they informed how long that process is? I think that would help the patient, the transition to know.
There's no doubt about that, actually. And, the basic, one of the basic concepts in patient experience is AIDIT. And the D in AIDIT is duration, which is about how long it's going to take for this to happen, how long it's going to take for that to happen. Challenge is that sometimes it's hard to know, and because somebody else who's not you is controlling when you're going to go to ultrasound or when you're going to go to, go to get your MRI, whatever it is that's happening, or when the consultant that you've requested is going to come and see your patient. One of the things that we do have that is a little advantageous in the ED is that we do have time standards for certain kinds of consults. So at least we can say someone from orthopedics will see you within the hour because we have some benchmarks around that they're kept to, as part of their performance metrics. So we can make some assurances around some things, but there's some things where we literally do not know, and that's a real challenge. I remember there's your old friend Dave McReynolds, who I know many here know, used to tell a story about rounding on a patient and being asked, so when's orthopedics going to operate? I don't know. When's neurosurgery going to come by? I don't know. And he had all these I don't knows, and at the end of it, the patient asked, so why are you here? I don't know. So it's just a tongue-in-cheek story, but the point is that, when you've got these complex arrays of people who are all functioning on their own schedules, it's sometimes very difficult to provide that information. And it's one of the, especially as a trauma surgeon who's trying to coordinate this cloud of people, sometimes it's very difficult to have all that well sorted out. One of the things on the trauma service that we've done, at least, is we have the orthopedic surgeons coming to our morning handoff, and they get to go first and tell us when they're actually going to do stuff. So when we go out and around, we can at least answer for them, which is huge, because that's about 2/3 of the surgeries that our patients get that are not us. So that's at least one thing. But this duration piece is a real challenge in healthcare. And
I'm assuming also you haven't figured out a way to predict exactly when level 1 traumas will be coming in the door.
yes, that then disrupt everything. That
Yes.
is correct. And that's the other thing is that, we want to say, well, when are we going to operate on you? Well, we're planning to do it at 7:15 tomorrow, and then suddenly something comes through the door, and then that's not happening anymore. And then that becomes a real frustration, especially if we don't have a minute to peel off and tell that patient who's waiting what's going on. So
In our triage process, do we triage patients that are more, could be more effectively seen like in an urgent care type of environment? And then do we have that type of service available that maybe don't need to actually be seen in an ER level?
We actually do. And, we have a great urgent care center right on campus, actually right downstairs here, and patients are directed over there from the main ED when they register, if that seems to be in a more appropriate site of care.
Do we track them to see that they actually get here, like you've got somebody coming over?
I can't speak directly to that, unfortunately.
Say again?
You actually bring them over.
Oh, you do? Okay.
All right.
What are the hours of the urgent care?
I think it's open, it's like, what is it, till 10 at night, but it opens at like 7, right? 7 to 10. It's good hours, actually. And it covers, really that big chunk, that mid-afternoon to late evening, where there's
Yes.
a lot of ambulatory traffic during that time.
That was a source of additional income for me when I was a resident, was working those hours up till 10 and even 7 a.m. So, and we saw quite a few.
Oh, yeah.
Yes.
It's busy, there's no doubt. And
It's still Main Street, right?
Yes.
Yep.
Most of your patients are on their phones, and it pops up when something has happened. So if someone is stepping out there, not the doctor, saying, we've got all these emergencies, it's going to delay, that would mean a lot. And that's the piece. And I don't think, even when they are saying, we're going to schedule you for x-ray, you're not going to be number one. It's going to be a little while. I mean, when they call to make the x-ray, somebody know how long it's going to be. So it's a matter of communicating it back to the family. So I think that's a major piece that we need to work on.
There's no doubt.
What happened here with our COPD 30-day? That's an obvious one that sticks out there.
Yeah, so the issue is that there are a total of, I think that there were a very small number of discharges in May, and so there was a very small number readmitted. If you look with that 50, we're still at 7% and well within goal for the year. So I think it's an N issue, a small N.
Is the number correct, 50?
Is that 50 patients?
No, it's a 50%.
Oh, okay, that's a difference, okay.
Yeah, it's a
All right.
50%. So I think it's like 1 of 2 or 2 of 4, one or the other,
Okay.
somewhere in that
All right.
range. So
Okay.
it's a very small number that, as you can see, is not hugely impacting the overall number for the year. And behavioral health continues to knock it out of the park, as it were, which is not unusual for them in their core measures. Our colon surgery is up a little bit this year, and we are addressing that. Hysterectomy is also up a little bit this year, and that is also being addressed. There was with hysterectomy, is actually pretty simple. We had solved this largely a few years ago by adding metronidazole to their preoperative antibiotics, and then that fell off somehow, and now it's back. So, pretty simple fix there. CLABSIs we've discussed many times. We're finally seeing some improvement. Finally, we went the month of June without having one, so that was really exciting, actually. There's been a huge amount of work going on around CLABSI.
Great.
And, you know, new insertion, better insertion bundles, insertion audits, new insertion kit with even better stuff, checklists, timeouts with checklist, and then a whole lot of work around line maintenance. We have a new product for Scrub the Hub, which is really key, actually, because you only have to let it dry for just a few seconds. With the usual alcohol and the other things they've been using to scrub the hub, you have to wait a couple of minutes. And of course, in the ICU, that doesn't really happen. You don't just sit there and wait for your hub to dry when you're doing stuff for minutes. You might wait seconds, but you're not going to wait minutes. So we've done a whole variety of things, and finally we're really seeing this move in the right direction, but it's been a big lift to move it for sure. But I think ultimately we're doing so many things better than we were before COVID that I suspect we're going to come out of this better than we were before, honestly, because I think the work done has been really outstanding in this area. CADI has been doing generally pretty well this year. Our hospital-acquired MRSAs also remains very low, which has been an area of strength. And we remain at pretty much, best in class in terms of Clostridium difficile. It's yellow because we're not really changing much compared to the previous year. We're slightly above, but we're really right where we need to be with that. So, and a lot of that is because of our antimicrobial stewardship and pretty decent hand hygiene. Not as good as I'd like to see, but pretty good.
All right, any other questions? No? All righty. Thank you, Dr. Stevenson.
Okay, thank you.
I think that brings us to the executive session. So let's take a 5-minute break. Okay. Take a 5-minute break and reconvene in executive session at 11:20. Okay. Excuse me. they going to tell us when we're back on? We're good? Okay, we are good. We shall reconvene in open session. Having, anybody have anything else before we entertain a motion to adjourn?
No?
Nope. I will entertain a motion to adjourn.
So moved.
So moved.
At the Medical Horizons Committee will please come to order. Thank you, everyone. Sorry we're running late. Blame Dr. Simmons for that. Are there any citizens who would like to address the committee today? There being none, we'll move to item 3, which is approval of the minutes from the May 9th meeting. Entertain a motion. Second. We have a motion and a second.
Mr. Montgomery,
Yes,
for the
ma'am.
record, I'm noticing that we have the same typo in your minutes that we had in the quality minutes, so we will change the date that the last minutes were approved.
Got it.
So if you all are still correct.
Okay, everyone take note of that. So noted. All in favor of the motion, please say aye. Aye. Opposed, motion passes. Item 4, Medical Horizon reports updates not requiring action of the committee. And I recognize Dr. Elliott.
Thank you. Thank you, Chair Montgomery. It's good to see everyone today, and happy Monday. We're excited to kind of give you some updates and just talk a little bit about what's happening in academic and research here at JPS and give you an update there. So thank you for the opportunity. All right, well, let's start off. I like to tell people it's the circle of life happening again. Everybody hears me kind of sing my Lion King songs as we approach July 1st. And so just to remind you, our circle of life goes from July 1st to June 30th. So we were so excited to welcome our new interns this past June as they arrived a couple weeks before July 1st to get oriented. So as you see there, we're just doing great things and even just growing and doing wonderful things here. We had about 74 incoming residents and then 10 fellows, so 84 trainees coming in to train with us this year. And now we've got about 227 docs in training here at JPS-sponsored programs. So it's an exciting time to see all that we're doing here as we're growing. We had our inaugural year for our hospice and palliative medicine, so 2 fellows joined us this past July 1st. We also, of course, really appreciate our partnerships across not only DFW, but as you probably see there, we have some military programs too now that we also work closely with, and about every month we welcome about 35 plus residents also across our network to work with us here and provide care for our patients here, and you'll see them there. We're also very excited that we have received accreditation notice from the ACGME for our Child and Adolescent Psychiatry Fellowship Program. This is indeed really, really great to be able to see that. We're excited to start recruiting. They've actually started that recruitment. We already have applications in place.
How many years will it be?
It'll be a 2-year program with 2 fellows per year. Yes. And so that's really exciting. That's been a partnership there as we've had funding also from the state through significant funding that is really targeted to make sure that we're expanding our mental health services and including training in child and adolescent psychiatry programs. And so this will be the first and only one thus far in Tarrant County. And it's also going to be really key for our patients here and to provide that. So we're excited to see that happen, and we're recruiting for that first class to start in July. Yes, ma'am. So we actually have in a couple of our departments here in surgery, we've had surgery and oral maxillofacial surgery. We actually have in those 2 departments, our program directors and chairs have really worked closely with looking at some of our other armed services to provide some care and been approached because we've provided such incredible training. And actually some of our graduates went into these areas, and so they were like our own ambassadors, and they came back and asked, your graduates have been doing so well, is there any way we could send other folks here? So we actually have, with our oral maxillofacial surgery, we have with the Navy. So with Naval Medical Center in Portsmouth, Virginia, and a Naval Medical Center in San Diego, we have 4 residents from them. And then in surgery, we partner with the William Beaumont in El Paso, and we have several residents that come with us there. You're welcome.
To try to retain those residents?
Yeah, we're always looking at those opportunities, and that's something I normally report on. We average anywhere from about 10 to 12% or so retention, somewhere upwards to 15%. But that's actually an ongoing initiative that we're working on with our physician groups in terms of that recruitment and hiring process, in terms of retaining our residents. So we really need that partnership to do that. So I'm excited to work with Dr. Becker and his group, also with our IAS group, and we're continuing those efforts to look at how we do that. We're actually also working with his group, with one of his team members, in actually getting in front of the residents very early, because I think that retention starts, that conversation conversation starts in the first year or second year to be able to see themselves here. So we actually are building, COVID, we had planned a program that was going to start in 2020. We had to put a pause on that, but we actually have a wonderful kind of practice management curriculum kind of thing to get them ready for that we're going to be rolling out too, in partnership with our claim colleagues there too, to look at that.
So there's a list of benefits. So if I came into the program, the benefits of staying here are.
Yes, and that's where we work with our recruitment colleagues there with our physician groups. And so, for instance, a recruiter with a claim is working with us closely to do that and make sure we're getting in front of them and having that exact message and communicate that message. Absolutely. So I'm hoping that we're going to anticipate even more as we move ahead and as we're growing too. And those are the conversations I'm having with Dr. Duncan, Dr. Becker, and all of our executive team to see how we can do that. All right. All right, so moving on from just a bit of that update, let's talk a little bit about clinical learning environment review. So I've mentioned this prior, that this is part of our requirements being accredited by the ACGME, the Accreditation Council for Graduate Medical Education, and they come every couple years to do what's called a clinical learning environment review. And under that, they're really looking at how our infrastructure is designed within the hospital and medical center, addressing 6 focus areas that you see there: patient safety, quality, and under quality, healthcare disparities, also looking at the way we're doing things in teaming, supervision, professionalism, and well-being. They also want to kind of look at what's happening in terms of our executive leadership. So they have meetings with our C-suite. So they'll be meeting with Dr. Duncan and our CMO, Dr. Miller, and others to be able to look how our residents and GME as a whole is integrated into the hospital medical center infrastructure. And so what are the areas for improvement? Our last visit was April 2018. COVID put a little pause on that. So we're actually pretty much out of that 2-year window. We're 4 years now. So we're really in the window that they could come anytime now. So what they do is they give us 2 weeks notice. And what we're trying to, of course, accomplish is to be in a continual state of readiness, just as we are with our Joint Commission. And so we actually stay very focused on this, working with our programs, our residency program leadership, and working with all of our hospital leadership, including nursing and everyone, to help us to do this. And of course, very closely with our quality team too, under Dr. Stevenson. And so I wanted to just take a moment on this slide because I wanted to highlight some of the focus areas that were identified at the last visit in April 2018, that they kind of said, hey, you may want to take a look at that and see if you can address some of these areas. And I wanted to just highlight some of the actions that we've already taken and what we're continuing to do. So in the meantime, we've also have a person on our team, a project manager, Tessa Watson, who helps us do all things clear and really focused, because this is such a big part of what we need to do. And so she works very closely with everyone across the network in these 6 areas. And so in the area of patient safety, one of the things they wanted us to look at are ways to kind of increase our education and engagement in patient safety initiatives. We definitely had some things in place and have expanded that in terms of educational modules for our residents, such as the IHI, Institute for Healthcare Improvement modules and things like that that they must complete prior to graduation. But we also wanted to expand that. So some of the actions that we've taken is that we've started some simulated RCAs, so what we call mock RCAs. And so we're rolling that out currently with our different programs. And then also how we're working with the quality team in terms of MIDAS and the monitoring of our safety event reports. So we're providing that now to our GMEC, where we can see where our residents and our faculty physicians are entering MIDASs. It's all confidential still and anonymous, but we want to make sure that they're being proactive in monitoring and reporting safety events. So we're making sure that we're keeping an eye on that in collaboration with our quality team. And then also, we've instituted what's called CLUES rounds. We're clinical learning environment walk rounds. So Tessa and some of us, we go around just kind of seeing how things are happening, or these areas are being addressed. And so that's kind of a fun kind of initiative there to look at that. So in the area of teaming, now this is a new area that's in place since our last visit. The last visit, they had an area called care transitions. And they've kind of embedded it also in these areas of teaming. But what they really want to see is how we're doing in terms of interprofessional teaming. And so what are the things we're doing to increase interprofessional education and our quality improvement processes that really have an interprofessional aspect to it. So some of the things that, of course, we're continuing to do, we had in place at the time was resident and fellows on hospital committees, but we're expanding that and looking at ways to even engage them even more so in our hospital committees. We also, this past orientation, this past June, we implemented the first Team Steps education, which was really exciting to do that. If you're not familiar with Team Steps, it's actually through the Agency for Healthcare Research and Quality, AHRQ, nationally, and they have a curriculum that they've designed called Team Strategies and Tools to Enhance Performance and Patient Safety. And there's a great curriculum that's really interprofessional. So we actually had all of our nurse residents and our interns come together, and they did a 2 to 3 hour big Team Steps curriculum. It was a lot of fun. They had a great time doing it. So it was really great to see that happening. And we're hoping that we'll look at that more and be able to expand that even in the future. Under the area of supervision, one of the things we wanted to make sure, which we also actually addressed this for our Joint Commission survey too, was education and the culture of supervision requirements, really ensuring that that's really transparent and very accessible. So our nurses know where to go to be able to see what the supervision requirements are for each specialty and for each resident and their level of training. And so that's actually been live for a few years now, since the visit. So we're going to be excited to show that. That was live during Joint Commission and compliant there, but it's on the intranet and very accessible, and we do that in collaboration with working with nursing, how to identify that. And then I mentioned the clue rounds earlier.
Chris, is this the summary of the 2018?
So yes, it's the focus areas are the 2018 summary focus areas. There were some strengths too. I didn't necessarily go into those areas, but I just wanted to show some of the areas that they told us to kind of look into, and then what the actions we've taken since that 2018.
Oh, for those that are interested, there's about a 40-page document.
Yeah, and I've shared it before, and if you'd like, but I've shared it, yeah. Yeah, you're right, it's about a 40-page.
All right, I read it.
Thank you, Dr. Weber.
Ready, bring it on.
Yeah, so this is directly from that and the actions we've taken subsequently. Thank you, Dr. Weber, for that. And then under quality and healthcare disparities, one of the focus areas that they wanted us to really look at is how do we increase education and engagement in our quality improvement initiatives. And also focus on our elimination of disparities, not just the fact that what we do daily in terms of caring for our patients, but what are we actually doing in terms of looking at outcomes in these areas. And so we do have quality curricula across all of our programs. Those are taught in our programs. We also do that in partnership not only with Tessa Watson on our team here, but with our quality team that helps us tremendously in facilitating that. We also are tracking, we have a tracker that we track all of our quality improvement projects that involve resident and fellows, and of course make sure that they're faculty mentored. So we have a tracking that we do, and we can provide that to our site visitor when they come. We also submitted our response actually immediately after that visit in 2018, just to highlight some of our other health disparities projects and things like that we were doing, and they received that. We also, as you've probably known, and you've maybe attended to, our Research and Quality Symposium each year, we've really focused on health equity, and we've really focused on how do we foster health equity through practice and research. And so a lot of our projects have been focused in this area, so I think we're going to look forward to be able to talk about that. And I'll highlight some things from this recent Research and Quality Symposium too, and upcoming. And then well-being. I'm really excited about what we're also doing in well-being, because since the last visit, we actually have a director of interprofessional well-being, Dr. Glenda Mutinda, who has been just a remarkable asset to JPS across the board, working collaboratively across everywhere to really help us in these areas of well-being. Many of you have already met Dr. Mutinda and worked with her over the last 4 years in doing this work. One of the areas that they wanted us to look at actually was how do we define and implement a process to identify care providers who may be at risk for self-harm or suicide, and that was something that's really important. And so we have actually taken actions with that. That's a collaboration not only with Dr. Mutinda, but with our EAP group and spiritual care and ethics and our behavioral health team. And so we're really pleased to be able to show that we are put a crisis response plan in place, implemented that. We have had the EAP Employee Assistance Program Wellbeing check-ins for our residents for the last probably four years now, and that's been working very well where our first and second years check in. And then we also have implemented now the Stronger Together peer support program, which I'll talk a little bit about that, which, you know, initially was kind of a second victims, understanding that our own, it's part of our kind of caring for the caregiver, but understanding our own team members have responses to adverse events or may have challenges too, and how do we empower our team members to care for each other. And so we have a Stronger Together peer support program that has been implemented where we've trained trainers across different departments and that they can facilitate some of this care for our own team members. And it's been an incredibly positive result there. But also I will say specifically on the self-harm and suicide, the training that we have implemented is called QPR training, well-recognized evidence-based program that reduces suicidal behavior and suicide prevention. Our two trainers that we have are Dr. Mutinda and Shannon Sims, who are certified trainers in QPR, and we've rolled that out to all of our residents, and now we're looking to roll that out to faculty as the next step in the nursing and otherwise how we can roll that out. So more to come on that. And then we have the professionalism area. And under professionalism, one of the things they just wanted us to look at is our conflict of interest reporting and just making sure that we were also transparent about our duty hours and ensuring that our residents were honest in reporting their duty hour times and communicating with our programs to ensure that our program leadership is also making sure they're monitoring that and making sure our residents are not going over duty hours. And so actions we've taken is actually we've done a lot of conflict of interest education and now some disclosures. So thank you, Colin, our Chief Compliance Officer, for all of his help in this area because we are now having our residents complete conflict of interest disclosures. That started with our new class coming in, and that will be a process that will be moving forward in collaboration with our compliance department. And we also provide a monthly monitoring and reporting of all of our duty hours to all of the programs every month through my office, and so that's also monitored monthly. So I just thought I'd just kind of share a little bit. We're in the window. They're going to come, but we're going to be ready, and more to come on that. Any questions on clinical learning environment review?
Tricia.
Dr. Elliott, you've done a remarkable job, especially as it goes to well-being and ongoing health and professionalism. Can you tell us, do you do a regular survey? Is that an internal survey? And tell us just a little bit about that goes out, that measures such things, and how do we do compared to whatever benchmark you have on it?
Absolutely. So interestingly enough, yes, we do. And I could probably bring that more to a future meeting if we wanted to do a little bit more in terms of that data. But under the directorship of Dr. Mutinda, we do a burnout inventory survey of all of our incoming residents, kind of track them and see how they're doing later. It was interesting when we started it a few years ago, they were actually a bit burned out to start with when we looked at it. And so that's something that we kind of helped us to build some programs to really check in on them and to look at that. I don't have the recent data for this year, but that's something we're looking at ongoing, and we always compare and we look at interventions to be able to address those needs. So those are things we do regularly for them. But we also do an annual kind of clear survey too, where we can, in these 6 areas, where we can also kind of see what's happening, what are things going, how are things going, what are the areas we need to focus on. So that helps us also kind of identify that.
And one of the things that also measures is fatigue management, so just your alertness and, the perception of feeling energetic, which has a direct effect on quality of care. So.
But yeah, we're always keeping an eye on that, and thank you, Dr. Haynes, that's a great point to say that we do keep an eye on that and survey that regularly. I can, absolutely.
I would like to see.
How we're doing in terms of the well-being?
Right.
A little more well-being? You got it. All right. Next slide. Just building upon our well-being area. This is what I mentioned in terms of our peer support program under the directorship of Dr. Glenda Mutinda. Also working very closely with our partners in behavioral health. I want to thank Zelia Baugh also, as she's kind of lifting up RISE with Shannon Simmons, and then of course Wanda and her group that are also focused in the areas of workplace violence. But we're definitely wanting to do this as a partnership and how we support all of our team members and our peers. So thus far we have 82 total peer supporters who have gone through training and or who are trained as such. We went from starting this in 2021, the first quarter of 2021, we started with about 20 encounters. We're now up to, as you see there, just year to date, 267. So this is being utilized definitely by our peers and recognizing it as a strength. Even in our recent Schwartz round, someone talked about the strength of that and how it was so powerful.
And you and I talk about this as nurse to nurse, physician to physician, kind of peer.
And it can be, yes. We train across.
Remember?
If you'd like. Sure.
But
Yeah.
that kind of peer.
Yeah, but that's exactly, yeah, it's that peer-to-peer kind of, so having those conversations. So you let us know if you'd like training.
Participate.
That's great. And so just to kind of highlight there, you see in the second column, some of the types of encounters, things that may be work-related, personal, patient-related, adverse events, so all of it, even when you've had an adverse outcome with a patient or just personally dealing with other things. So just to have that support, and so all of our trainers are also know the resources to be able to refer to if they need to refer. Okay. All right. So let's talk a little bit about some student updates here too, and just in our overall pillars as we're looking at workforce recruitment and retention. And some student updates. Just thought it would be nice to highlight to you how many students we actually have come through our doors and that we're training and we're pretty busy with. So as you see there, close to about a little 2,500 plus students that are projected to rotate with us this academic year, and we offer several rotations, some of them rotating in different specialties across the network. And so we have over 118, we have 118 academic affiliations. And so we were looking at ways also how to kind of really maximize the experiences here. And I think to Reverend Emerson's point, this is an area too also, Reverend, that we're looking at for retention purposes too. And so we're working with, we're going to be working with HR and our nursing leadership too, particularly to ensure that we're looking at ways to retain. We normally retain an average about probably 11, we've ranged anywhere from about 9 to 19% retention in our nursing, so averaging about 11 to 14%, but we're looking to expand that. In our allied health area too, we're also averaging about 17% retention. I will say one of the things in allied health is that we get a lot of applications for our pharmacy folks, but we don't have necessarily a lot of spots for that. But our rehab services, boy, do they love our students, and so they're a huge part of our talent pool for our rehab services. But also nursing, I will say across the board from our OR, endoscopy, women's postpartum, NICU, Tower 7, oncology, all these different areas that look to our students to be able to do this. So we're going to be working closely to look at other ways that we can even build this retention model too and get them more experiences.
Go ahead.
I was going to say for the pharmacy, is it just because of shorter spots, it's a smaller department, or is it tech that goes?
I will just say it's probably just a matter of positions being open and availability. So the band is high, which is great to see, but it's just a matter of what our needs are too.
Under retention models, are there, and people may not be willing to discuss it because they don't want you to steal their ideas, but are there best practices around how to retain people? I mean, do some people do it better than others and we can steal their ideas?
Yeah, yeah, probably are, and I'd love that. So actually, I'm looking forward. Actually, Carla and I are going to be talking, and with Jill too, and looking at some of those models and talking about some of those models, even being able to give, early, offers or just identifying them early and being able to do that. So I'm going to be actually relying on the expertise of our HR group to see what those models will be.
Yeah, steal shamelessly. They work for the Beatles. Do it.
I like it.
Dr. Elliott.
Yes, ma'am.
When you're talking about our retention and recruitment.
Yes, ma'am.
In our specialty areas, are there any goals for fellowships in some of those specialty areas? And what is the requirement for us to increase the number of fellowships?
So are you wanting to think about medicine fellowships or other types of fellowships?
I didn't have anything in mind, but I'm thinking that we have a large specialty group that is aging.
Yeah.
And so how will we recruit for that?
Yeah.
And so do we have something in place or a plan?
Yeah.
And usually that's through fellowships, right? And so I don't know if we have any, if that's a part of your goal, which it should be, because as we grow and as staff age out, we need to have some way of having them to be exposed to us to stay with us. So
Absolutely, absolutely. Yes, and it is definitely, Mr. Bose, a big part of our plan and goal and vision. Absolutely. It is part of the strategic goal looking at that. So I will say specifically around medical specialties and looking at that, I think we've grown in some of those areas a little bit, like I've mentioned, through hospice palliative medicine and through child and adolescent. But you're right, some of these other medical specialties, we're looking at how do we grow those in terms of cardiology or GI or these other types of specialties that we need to also focus on. And so those are some conversations where we're looking at what do we need to grow internally, what do we need to establish internally to do that. And so I'll be working with Dr. Duncan and all of our folks to look at that. But we're also have some conversations and partnerships working with some of our folks like Baylor All Saints and things who are growing their own, and looking at some joint ways to be able to actually even earlier to be able to get some of those kind of specialty models here and integrate them that they're here, similar to what we kind of do with BUMC and things like that with surgery, but in the specialty model. So those are specific conversations. I actually just had a conversation last week with their DIO and mapping that out, and we're going to be meeting regularly this year to kind of look at what that is. But you're right, we need to look also internally what that needs to look like in terms of growing that, and so that is on the vision planning, absolutely.
Okay.
We've had some successes like in GI, partnering with Plaza, their fellows come over still, and I think Acclaim has now hired a couple.
Great.
That's a perfect example of, community partnerships where we have a need, but to grow our own.
Right.
And I know Baylor also is looking into that direction. I think we're going to have some.
Okay, we're good. I'm not saying we have to grow our own,
Yeah, right.
but I do think we need to have a plan and to be a part of that, and to look at the specialty that can help. I'm used to working as kind of as a team, so there are some specialties that we don't have that we probably need to look at them being a part of the team.
Yeah, absolutely. And those are very, very strong conversations happening right now, as I said, to be able to do that. So I think GI, cardiology, even nephrology, and we're looking at also areas in, I'm sorry?
Urology.
Yeah, we do have urology who rotate with us. We have ophthalmology and neurology in terms of surgical subspecialties. In terms of the other medical subspecialties too, like pulmonary, critical care, things like that too.
Yeah, I know no one want to hear me say this, but I think one of our team members that we need to look at is having a few internal medicine to become a part of it. I just think that's a part of the team that can work well with what we are doing.
Yeah.
Okay.
Absolutely. And we can definitely explore that.
When you look in the marketplace also, and especially important in the competitive nature is to develop student loan repayment programs and to work, to be attractive, because when you look out there, those are really, so in each of these areas, all of them would be very attracted to a student loan repayment program.
Yeah, I would support that.
And we've actually started some of those conversations and looking at that. I've talked with Lauren too, where we're looking at some things with HPSA designations and things like that, so we can be a part. And I think I mentioned that as some previous things, that those are things we're definitely exploring for loan repayment, not only for medical students and for residents, but for nursing also. It does.
Yeah.
And allied health.
I'm not excluding nursing, I'm not.
Yeah.
And allied health, none of it. I just think that our plan should be.
It does.
I mean, we should open our mind up and kind of, we can dream big.
Absolutely. And I'm hearing you open our mind up to think about what medicine looks like and medical specialties, nursing specialties, other specialties, and make sure that we're part of that and making sure we're growing that. So
And I know that on the hospital side for the fellowships, there might be some requirements, but we need to know about it and put that as a part of our plan.
I appreciate that.
All right.
It is part of our plan. Thank you, Ms. Bose, for the support on that too.
Thank you.
Appreciate that. All right. Any other questions on just kind of the student updates? Just thank you for the support of our students. All right. Just expanding a little bit more on students. We're kind of excited. I mentioned this in a previous presentation that we were building this and looking to start this. And so, yeah, we are starting it. And thank you to our foundation and to our finance group. They have been incredible to help us kind of lift this and to launch this. Thank you, Cheryl, and thank you, Sharon, to your group. And so part of this, as we recognize, is that we've got to make sure that our students really get the experience here at JPS and be able to do that. One of the things we recognized that was happening nationally, actually over about 100 plus of these scholarship programs are happening and posted on the AAMC website. And we wanted to be a part of that, is to be able to offer scholarship programs to underrepresented students who are identified as underrepresented in medicine. And, okay. So those students particularly right now, so we wanted to start a pilot and kind of launch this and really track this and see how we can do and grow this. So we're going to be working with our foundation. URM is underrepresented in medicine, and those are actually defined right now. And there are different ways, but the initial kind of thing they're looking at around specifically in areas of certain race and ethnicities that are underrepresented in medicine. Those that they have identified that are URM or underrepresented in medicine are Black African American, Hispanic or Latino, Native American, Alaskan Native, Pacific Island, and Native Hawaiian. And so those are the areas that they're looking at because they're not very highly represented even in the medical school class and in medicine as a whole. So can we advance our diversity and really grow in that area? We do understand that there's probably some other areas of underrepresentation in medicine that we will probably build upon and look in the future, but this is an area that's a high focus area nationally for a lot of organizations, not only our national organizations, teaching organizations, but just in terms of the AAMC, ACGME, our accrediting bodies, they actually require us in our annual reporting that we're doing, we're in the process of doing now, to show what are we doing in areas of diversity, equity, and inclusion and advancing diversity, and what are our policies and practices around that. So, we like to be able to highlight that we're doing this collectively, and of course, we're going to be working with HR and our new consulting group too to look at some of these areas too. So this is just one strategy that we had wanted to put in place because it really does matter, and we've recognized that we're not in the space that needs to be in this space to offer this. So we were able to identify funds to be able to start this pilot in our foundation funds and work with finance on a model and a process to do this. So our goal is to increase the number of underrepresented in medicine participants who are doing their fourth year elective rotations here at JPS and include a scholarship opportunity for them. So upwards to about $2,000 to defray their costs in terms of travel, housing, and living expenses. As you probably know, students go all over the country to do their rotations, and that cost is usually the cost to them. And so we want to be able to not only that they're already applying here, but to give them an opportunity. So we're hoping we'll see even more students apply. Right now in the DFW area, there were only two other institutions that offered this, and I was like, well, JPS can't be left out of that, so we need to make sure that we were part of that. And in Texas, we're now only the fifth program to be able to offer, fifth institution to be able to offer that, and knowing, like I said, there are 100 plus in the country. So I'm glad that we're able to do this. We already received about 17 applications, and working with the programs and our staff and a whole selection process that we did in these particular areas, we've identified 7 folks who will be our pilot first folks to receive this. And so what's your total? Sure. So right now we had 6 of these. So there's 1, 2, 3, 4, 5, 6 key departments that we were looking and programs we were looking at to offer $2,000. So 4 times 6, we started with about 24,000. So just small, just to kind of start small. We identified right now probably in that budget about 40 to 45,000 in that budget right now. And then we're going to be working with Cheryl to do some developmental processes to build that, but we also want to make sure that there's support here. If we want to if this starts to be successful, this may become an item that line item, in a future budget. But we wanted to start it and just really kind of build it and see where we go.
I made eye contact with.
I know, right? I did.
Her eyes down. She averted her eyes. And also for the foundation, this is a great thing for people to want to give to the foundation to say, that's something I want to bring to my community.
Oh, I love that, Dr. Yes. So, yeah, we'll get a campaign launched for this, and we're excited. Yeah, I think it's definitely what we want to do and see happen here.
How is URM incorporated into the match?
In terms of?
In terms of, do the URM applicants then get a little higher priority in the match?
Well, that's not necessarily, remember, the match is a different thing. So we've got to look into things, what we're going to be looking at, first we want to increase the number of URM applications, period, in areas that come to us. So we're hoping this visibility and this opportunity increases their desire to apply, right, and be here and see themselves here at JPS. I think what's nice about it is that they'll be here in their fourth year elective, and so they'll get that like 1 month experience and really do that. So it's like this kind of integrated, embedded experience. And so they'll likely get interviews, so maybe a greater chance of getting interviewed. And so that's what we're going to also track too, an increased number of URM candidates that are interviewed, and then ranked. I mean, then they go through ranking. Now, we cannot dictate ranking to that I leave that to the program directors, but I'm hoping with that, of course, you have more in the pool, you have more people who are ranked, right? And so it's kind of be one of those things that we're hoping that we can see that and that experience grows. And so as they're doing that, but understanding the match is also them matching us, not only us matching them. So we're hoping that that experience allows them also not only to match us, but us to match even more URM students too. So I will hope that we'll see that. I do think it's not a one-year process, and I want to say it's a journey, as we've all been saying. So we're going to be tracking it for a few years for sure. And we've already been tracking those numbers anyway in terms of our URM applications, interviews, selections, and things like that, and matching. So we actually have been doing that for the last 3 to 4 years, and so we'll continue to match that and see that trend data, to your point. Thanks, Dr. Haynes. Yes, we do, Reverend Emerson. We absolutely do, which we're excited about. We have a few coming in from there. And so I actually personally was at the fair at Howard back in March, and I attended that fair because I wanted to personally kind of launch that and show that. It was kind of exciting because the students were like, we didn't even know this was happening in Texas, and I've got a family member in Dallas, and it's just making the connection for them, right? And so Howard, HBCUs. Sorry, I shouldn't. Yeah, HBCUs, historically black colleges and universities. And so for the medical schools, there are 4 identified HBCU medical schools. And those are Howard, and then we have Morehouse, and then we have Meharry, and we have Drew. Those are the 4. Just of note, Xavier in Louisiana announced that they will be opening a medical school too in the near future. Yeah, Howard invited us and we went. And so that's one of the ones. We're looking at some of the others too that we can actually be able to contact and do that work with. We also attended the Student National Medical Association National Fair, which is a branch, the student branch of the National Medical Association, which focuses on our Black and African American students nationally. So we attended that. We were actually blasted and Instagrammed out. They love JPS, so we were doing a lot of things there. We also attended the LMSA's, the Latino Medical Student Association National Fair, so we've done that. We're looking for more opportunities. We're going to other schools too and doing this. We're also going to be hosting this month a virtual either this month or next month, we're hosting a virtual diversity in medicine recruitment. So we're going to be inviting underrepresented in medicine folks from all of the schools around and trying to kind of do a little ad for them to come and see us virtually. So we're going to be hosting that virtually. So a lot of efforts happening. We want to continue the efforts, not just make them one of, but make sure that there are things that we can continue to do. But we're launching some things now that we had to kind of put a little bit on hold with COVID, but we're definitely doing a lot more efforts in these areas too, Reverend Emerson. So I really appreciate that support.
Dr. Elliott, when you are hosting that, it's not just you, is
No.
it? Oh, okay.
It's actually, we want, all the programs will be represented. So we have residents, our own residents, because they don't want to talk to me, Mr. Bose. Actually, I will tell you, when I went to Howard, I had 2 residents with me, because I'm just there to be like the chaperone and be there in a show like this. Too slow, okay? Not that they need chaperones, but I had 2 amazing residents, one from psychiatry and one from emergency medicine. They did all the talking. I was there just to be the backup to say, because the students want to talk to the residents. So even virtually, when we host this and we go to these fairs, we send faculty and residents, and I send a couple, and I send staff.
Yeah, I wanted to make sure that faculty was a part of it,
Yes.
since they're going to have they select us and we select them, so,
Right,
okay.
yeah, faculty, residents, and staff.
Okay.
All right, so exciting. All right, more to come. It's a journey. All right, let's shift into some research and innovation. All right, so I wanted to, as I mentioned, as we're promoting research, scholarship, and innovation, a couple of highlights we're going to talk about. So in June, this past June, we hosted the 2022 Research and Quality Symposium. We had record attendance. It's now virtual. It's been virtual since 2020. And actually, it's been a win that it's been virtual. So we had over 334 attendees, 320 abstracts. I mean, that is amazing. So we had a lot of abstracts there. We had 15 abstracts from researchers outside of Texas and even 3 international researchers. So I like to say we're national symposium now, but we're almost international now in terms of that, which is great. We had those live posters, 43 live posters, and lots of gallery posters. And there's a link there too, and you can go and take a look at some of these posters and things that are still up, and it's great to see that. So thank you for your support of that. I also wanted to mention too that we're definitely advancing in our scholarly activities, and we've grown significantly with a good focus area on that, because not only are we required to do this in terms of our accreditation purposes, but it's the right thing to do, right? We're advancing evidence-based practices and looking at those outcomes and things like that. And so being a teaching institution also, we want to make sure that we're advancing our scholarship and our scholarly output. So we have definitely had growth in that area, and I want to say kudos to our research teams, particularly our Office of Clinical Research under Dr. Melissa Acosta, and our Center for Epidemiology and Healthcare Delivery Research under Dr. Rohit Ojha. And I want to thank them so much and their teams for what they're doing to help us move this forward, because even with this reporting, we have to actually give this list. They compile an amazing list of all of the scholarly output for us to provide to the ACGME for our continued accreditation purposes too. So it's really helpful. We also, as you see there, has not only grown in our scholarly activities, but in our publications too, that actually have a JPS person or JPS researcher, somebody that's identified on these publications. And you can see our growth there significantly there. What's also exciting, and I really want to give kudos to the team again, and that I mentioned, and also in partnership with our medical library with the Health Science Center, is that we now have a publication, JPS-specific publication database that links to PubMed ID and PubMed.gov. And if you're not familiar with PubMed, it is actually the premier site to really identify indexed publications worldwide, with over 34 million citations and abstracts, and it's under the National Institute of Health and National Library of Medicine. So what's nice about this, and if you just go to either the intranet or you just say JPS Medical Library, it can take you there, you'll look at it, and you can find it there, and you can actually just put in a name or just see the list for years from 2017 to 2022, all of our JPS-specific folks, and then link to that article. So that was a big endeavor to develop that database. So, yeah. So we're pretty proud of that. I'm proud of the team for that. Also, based on our last meeting, I wanted to come back. You mentioned just let's highlight a few of our collaborations and our emerging opportunities. And just these are some of our local partners, too, that we collaborate with in some research and innovation. There's many more beyond this, but I just thought we'd highlight some of these areas there, too, in terms of our partnerships with TCU Health Science Center, UTA, Moncrief Cancer, and UT Austin. And in the next slide, what it is that I know some questions came up specifically around oncology and cancer care, and what are some of the things we're doing in that, in the area of also of HIV and cancer care. And so this is just to highlight here some of the, for instance, our oncology-specific clinical trials. We are working closely with UT Southwestern. We're part of this cancer research group that you see there with certain studies focused on breast cancer and prostate cancer. We also have clinical trials looking at metastatic breast cancer with University of Arizona, several with the Health Science Center, some industry-sponsored ones too. We also have some grants about ending, for instance, ending the HIV epidemic. That's with Tarrant County Public Health to build this HIV informatics infrastructure. That's with one of our Ryan White collaboratives there with them. American Cancer Society also, we have a grant that's part of a national collaborative to improve our cancer screening. Particularly the focus right now is colorectal cancer, so that's one of the grants there. Also, we have in terms of CPRIT, there with Moncrief, like we mentioned there too, in UT Southwestern to enhance our hepatitis C testing and treatment, knowing that that can be, hepatitis C is also a risk factor for hepatocellular carcinoma cancers, and so some of those areas there. An action grant is an NIH grant that working with TCU and Yale to improve our linkage of care for HIV and looking at opioid use and overuse there. HPV, human papilloma virus, that's one of the areas too. Human papilloma virus is associated with cancers in terms of particularly most commonly cervical cancers, anal cancers, and oral cancers, and so working with those partners you see there. Also one with UT Dell as we're looking at opioid-based treatment. So lots of things. I just thought I'd just highlight a few of them up here, and like I said, a few other industry pieces there. But this is something we're continually looking at and growing, and much more to come.
Okay.
Those are under like drug studies, and so whoever is sponsoring that. So if there's one of our physicians who has an interest in this area, then we look at the ways we partner, and sometimes we're approached, and then we vet that and look that closely. Yeah.
Can I ask a question before you leave?
Yes.
Those pages.
Which one is it?
I'm still on page 11.
Yes, ma'am.
Where you're talking about the JPS publication database.
Yes.
From studies. And I'd like to know how many studies are we talking about that's in there?
How many in the PubMed ID right now?
How many are we doing, JPS have done? When you go back to your JPS publication data, and it's talking about...
well, I'm not sure how many in terms of the publication, but I can get into how many studies in terms of like IRB-specific studies in the coming up, if you'd like a little bit of that.
Yeah, how many of those are, how many have we had, how many are open, and how many have been closed?
Got it.
Okay. That was the next part of my question. Okay.
Sure. All right.
Okay.
Yes.
I just had a question. How on pace are you to match the goal? How on pace are you to match the goals from 2021 on the scholarly articles?
Oh, in terms of just improving, we definitely, probably exceeding it. Yeah, we're doing pretty well. Yeah. Awesome. Yeah. Okay. Yeah, we're hoping we're going to be there. Yeah.
What happened in 2021? Was it because COVID, they had time to do all the research?
You know what? Yeah, we just, we had, I think, shifting to certain formats. Yeah. It could be. I'm not quite sure. I know some things with the virtual pieces allowed them to kind of do some things, a little more accountability too.
All right.
So
Okay.
that's a good point.
Okay.
Yeah, I don't know if we'll hit that again. That's, yeah. May have been a blip. All right. So let's talk, so just a little bit about you'd asked for a bit of an update on the North Texas Regional IRB. In terms of our promoting research and scholarship here. This was formally established in 2017, and it's a joint partnership institutional review board that we work with the Health Science Center here locally. One of the goals in that was really how we can foster collaboration, also increasing our regulatory compliance and decreasing our regulatory risk and our patient financial and regulatory risk for JPS. It is, I just wanted to kind of talk a little bit about it. So there is an IRB office team at the Health Science Center, but we also have not only that external team, but we have our own internal JPS IRB team that helps to kind of look at making sure that it's meeting all of the needs here at JPS and it's in compliance. So we do have a research integrity team here. That's 3 of our staff here at JPS to facilitate that collaboration, that initial review. So when we are approached, we do the initial review, submissions and compliance, and then moving it forward to the IRB IRBs. So that is very helpful in terms of that piece. And of course, there are also commercial and clinical trials and other types of commercial IRB things that come forth. Yes, ma'am.
Okay. On your internal team,
Yes.
you say you have 3 staff. Are those the same 2 JPS physicians that's serving on the IRB?
No, I'll talk a little bit about that. This
Oh,
is
okay.
actually our JPS staff. This is actually under Dr. Melissa Acosta in my Office of Clinical Research. I have Andrew Adorbo serves as Manager of Research Integrity. And then I have my team member Carissa Jensen, who's our Research Integrity Specialist. And then we just had a recent open position that we're looking for our Clinical
All right.
Regulatory
Thanks.
Specialist.
Thanks.
But yes, I'll come back up there too in terms of the structure of the IRB team there too. So the IRB board members, there are 13 scientific members, 2 JPS physicians, actually, and a 3rd physician who serves as an alternate member. We have Dr. James Etienne, who's emergency medicine, Dr. Ivan DeCasada, who's our new radiologist, and then Dr. Del Moore is our vice chief of surgery, also as our alternate there. We also actually have had 3 JPS nurses too that are part of that. We had 3. One nurse member is no longer with JPS, so our 2 that are being appointed to be able to serve jointly in this position there are working together. Will be Ms. Yarborough, Renee Yarborough, and Carmen Godot, and they're working very closely too to be able to facilitate that. So we do have definite oversight and membership and interfacing with that. There are community members also, as you see there, non-scientific members. They do meet monthly. The IRB board meets monthly to review full board protocols. The IRB meetings meet, and all other protocols actually are reviewed in real time. So we don't just wait for that. If there's something that precedes that, we need to make sure that they do meet and look at that. And so that is kind of the board structure and how we make sure that there's representation there on our end there. Like I said, the internal structure that we have is to make sure that we're really looking at also our JPS specific needs and oversight in terms of all of these submissions there too. And even if there is a commercial IRB protocol, we review all of them to make sure that they're aligning with all of our compliance needs here. There's also a new IRB management software that's been implemented called IRB Net. That has actually been just a win in terms of facilitating more efficiency around online submissions and reviews. And of course, with COVID, we had to kind of shift and so the meetings also shifted to virtual meetings too. So that actually has increased our board engagement having that. So that's also ongoing that we're looking at that. I will say, one of the things that's been helpful in this whole process here for sure, in terms of understanding the structure and kind of this partnership, it really has helped us to kind of minimize our research risk and really kind of had a benefit and a little bit more research oversight and that regulatory risk. It's a very common I will say we wanted to kind of research and see like how common is this kind of partnership in looking at working with a teaching hospital, county hospital, working with an academic health center to be able to facilitate these IRB reviews. And it's actually quite common. I think we actually did a little research and found out even that, for instance, Parkland, UT Southwestern, and even in Houston, we see Ben Taub, LBJ utilizes those health science centers that are there too, locally. And then even across the country, many of those from Cooks to Grady's to everywhere else utilizes these academic health center structures and partnerships to do that. So we definitely, though, I think what's beneficial for us is having that internal piece too and that oversight. That helps us to really make sure that we're keeping our eye on everything that we need to be able to accomplish here and we're in compliance. I will say that we work with all IRBs to provide this research oversight from our research integrity team here, and we make sure that all research protocols meet our policy and procedures. We've actually created SOPs, standards of operation, procedures and policies in place for all of this, and we've worked with compliance on that too, who's looked and reviewed all of those SOPs. And so we make sure that we're ready, and so we're ready if there is any auditing, that we are fully in compliant with all of FDA and all applicable federal and state regulations there too. So I just wanted to highlight that. As you see some of the successes there, I do think from this is that we've definitely seen an increase in protocol submissions. Right now, we've got about year-to-date for JPS specific submissions, new projects. Mr. Bose, we have about 187 new projects. And continuing review, we have about 22 in continuing review. The ones that are going through modification review are about 41. So a total of about 250. We've definitely seen an increase in that, going from anywhere of just having about 20 to now over 200 plus. So it's a significant increase that we've definitely seen in the benefit for that. And then cost reduction, we've definitely looked at that, and I think as we've grown, we've negotiated that cost down, so we've actually decreased that cost as a collaborative, in the collaborative, by 30 to 35%, increasing even our cost significantly from when we were prior doing it without the partnership. It's been a significant cost difference. I will say our current cost per protocol now for JPS, if we look at it through the North Texas IRB, is about $1,200 per protocol, and competitively, if we were to utilize any other commercial IRBs, it's about $2,000. So we're definitely seeing cost reduction there, 37% cost reduction in IRB fees by utilizing this model. And then the collaborative grants, we've definitely grown in those grants too, and collaborating with the Health Science Center, so it's allowed us to be able to build some grants and some models there to be able to support our patient care and evidence-based practices here, and that's grown significantly there too in those partnerships, and so it's been able to facilitate some of that. Okay. And then the increase in scholarly activities, as we mentioned, and also increase in resident and faculty engagement in clinical research. And I think definitely having our 3 physicians and our nurses a part of that is definitely something that's going to be very helpful, and it's also increasing our nursing research too. And so we're looking forward to advancing our increases in our nursing engagement and working with our nursing research council too.
Okay, is JPS still 100% contracting with them for that?
For the IRB, for our IRB services are fully contracted with the North Texas IRB, yes, we are there.
Did our costs go down now that they have other members?
Our cost has gone down significantly, and that was where I said the cost reduction. We've seen our costs reduce over almost 30% since we initiated this in 2017, and our cost has gone down. As far as like other members, we are the joint with them, but they do have actual other requests that often come about in terms of protocol reviews. So other organizations that try to actually request protocol reviews, they've had Cook Children's do a few NIH reviews, and so requesting the North Texas IRB to do those reviews. UNT Dallas has done that. And also Tarrant County Public Health has actually approached the North Texas IRB to do those reviews too. So we actually get those requests that come in that. Okay. And then we've also seen a significant, like I said, a cost reduction too.
So I think my question that I was trying to say is when this got started.
Yes, ma'am.
We contracted for a large amount to give to them.
Yeah.
So now that contract amount should be down. Okay. And I'll get that from Sharon. She'll be able to tell me what our reduction is.
Yeah, and I can share that with you if you want afterwards.
Yeah. Now that it's growing and it's standing on its own,
yes.
I don't think we ought to be the one that's constantly feeding.
Right, and I will just say what's really great about it is to say that, when we were initially doing this, you're talking about 20 to 30 protocols a year. Now we're up, like we said, 200 plus protocols. And with that, yes, the cost has gone down.
All right.
Yeah, and I can share with you what that is. And that contract comes here to the board too. So we always make sure that that's fully transparent.
I don't remember that coming forward again. That was one of my thoughts. Okay.
Dr. Elliott, could you recap for us who makes up the North Texas Regional IRB? What institutions are represented?
JPS and the Health Science Center.
That's it?
Yes.
Okay.
Yes. But they also do review, other protocols as requested from other organizations. The UNT Health Science Center. Yes. All right. And I'll just say, I think some of the questions often arise to say, well, where are the other partners? And one of the things, too, is just recognizing, for instance, our other hospital partners here. So, THR is affiliated with UT Southwestern. So that's their affiliate and that's their IRB that they're going to be using. Baylor also is utilizing with BUMC, and they're facilitating that. And I will say with TCU in particular, to see with the medical part of that, what's nice is they have a distributive model, so all of those research protocols and research projects that require those IRB have to go through that hospital's process of IRB. So even those projects that they're doing, it comes through our North Texas IRB. If it facilitates through us, if it has to deal with our patients, it goes through our process. If they do it with other hospital partners, they have to go through their IRB process. So for their medical research, they have to utilize that model. For their non-medical research, they of course have their own other IRB models around that. And so, yeah, so we do look at that, and as I said, Cook Children's, one of the things around that is that they look for us to be able to provide that as needed. North Texas IRB, they do those requests as needed. Okay. I did want to just highlight to everyone, one of the big wins, I think this is huge, is that we have now centralized our grants process. So we know that there are a lot of grants that are happening. We knew that across the organization, but we recognized that we needed to really facilitate a process to be able to centralize that and bring all of our sponsored programs under one umbrella. So I want to thank Dr. Duncan and Sharon Clark and Lauren Poe, particularly as we kind of looked at this and trying to developing this. And definitely want to thank Cheryl Sutterfield-Jones and the foundation too. So this is really truly a joint partnership, like as we've kind of looked at this, working with the foundation, working with finance, our research and academic affairs team, IT, legal, compliance, everyone to be able to facilitate this and make this happen. So our goal was to basically centralize the development and the oversight of all of our patient care grants and all grants that were awarded to the Tarrant County Hospital District. So those grants that are particularly in our name. And those sponsored programs will help us to guide all that we're doing strategically. The challenges that we identified before and why we really decided that we really needed to do this, and Dr. Duncan in her foresight really charged us to do this, to say we had a lot of decentralized oversight and it was really creating some inconsistent processes. And so there was definitely causing some things around system burden, suboptimal alignment, and also suboptimal financial management. So sometimes not necessarily tracking this or not necessarily utilizing all of the funding or doing the appropriate rollovers and requests and things like that. And we needed to make sure that our clinical providers were the principal investigators in these programs, because we're driving evidence-based and trying to change care models. And so we don't just want to have one-ofs. And I will tell you the three things that really we look at in terms of looking at grants and when we're looking at the opportunities around this, and that we actually charge when people come and say, hey, we want to look at this. We say, first and foremost, where's the alignment? Okay, so strategic alignment is very, very key. And so we ask about that. We also say, what's the feasibility of us being able to really do this? And so alignment and feasibility, and then last and not least, sustainability. So those are the three kind of the lens that we're looking at all of the things in terms of these grant requests. And so that's why I think as we looked at those challenges, what were the opportunities? Then we said, you know what, if we can centralize our grants process and develop consistent processes, similar to what's happening in well-run areas, we want to increase the way that we integrate these programs into clinical areas and really track these outcomes and connect our patients to these therapeutic options and therapeutic services. And so also it'll allow us to heighten our focus on the philanthropic development, so that kind of taking this out of that kind of area and having the foundation really focus on their gifts and developmental piece, and us focusing on what's in the Tarrant County Hospital District and grants and driving that area. And then it would allow us now to centralize that, to really keep our eye out there to expand potential funding opportunities and really look at that. So we're looking at some software development, some things that we're going to be doing and integrating to be able to really go out there and find those things that are going to be relevant for us and really helpful for us and our patients. It also helps us to reduce audit and compliance risk, right? And so working very closely, like I said, too, with legal and compliance around this and reducing the burden on our system resources. So what we did was we created this centralized group called Sponsored Programs. It's now within the Division of Academic and Research Affairs, under Dr. Melissa Acosta. And so sponsored programs, I'm really excited about the team. We have our manager is Margie Blake, our senior grant coordinator is Eugenia Hollis, and our grant coordinator is David Lee, and they're already up and running and moving, and it's only been probably 6 weeks. So they are really, really eager and moving forward and building models and tracking and looking at what we're doing in terms of expenditures and things. And so it is very closely aligned. It's going to be working with our business planning committee, which will be vetting a lot of these. So as these come forward, we'll help with those investigators and everybody pulling it together. It'll go through a process of being vetted and reviewed with our business planning and ensure that we're meeting all those three things, right? So alignment, feasibility, sustainability, where are we financially with all that? And then working with, of course, our finance and foundation as we see these opportunities evolve. So it's going to be more to come on that, but I just think it's an exciting thing that we are now in this process of having this here at JPS, a sponsored programs department under research. And so I think that may be my last slide, unless I have any questions around decentralized grants.
Any questions for Tricia on any of this?
Oh, great. Any other questions?
We did not have any items requiring actions. That's correct, Council?
Correct.
And we have no items in closed?
No closed session.
Wow. Look at that. One thing I did want to... Sure? A heck of a lot better than Shannon. Let him know that, too. One thing I did want to urge my colleagues on the board, especially the clinicians, but all of us, Reverend Emerson and Amanda, is ideas that can help support what Tricia's doing. Let's bring them forward. Let's push them out. Bring them to me. Bring them to Tricia. I mean, we really want to help support what she's doing because it's so critical to what this organization does. So don't be bashful. And I know none of you are bashful. So, bring.
We got a few shots.
Yeah. Who? Yeah. Who again? But truly, bring your ideas up. We want to try to support this effort as best we can and push forward, push the envelope until Dr. Duncan says we can't. All right. Any other questions? Any other items? Oh, the money person. Yeah.
She finds it. She's great at finding it.
Yeah, and we're good at spending it. So. Any other questions for Tricia or anything? All right. With that, we are adjourned.
Oh, you're welcome, Mr. Bowes. Thank you. My pleasure.